We can see.
All right, thank you. Good. So today we're going to discuss on acute spinal cord injury, because I feel like this is also a very important aspect for us as physio, and so we'll be having discussion on this, on how we can support our patients acutely. So let's get started. But before we start, I'd like us to quickly have a quick reflection on everything we've been doing, so everything we've done so far. So is there anything anyone has put into his or her practice? Is there anything we feel like we need further discussion on, or is there anything we've been take away from all of this seminar and we've used that to facilitate our patient care, or anything like that, or anything somebody would just like to just have a reflection on for us? And we have a quick reflection because it's important, it's equally important. We'll talk about some of those things as well. Hello? Can we have somebody, just a quick reflections? Is there any part of this discussion in the past that has actually made any sense to you, that you have implement the knowledge gained to your practice? Or is there anything you feel like is just pure rubbish or something like that? So is there anything, can we just have somebody to just have a quick reflection before we start?
No, bro.
Yeah, go ahead. Hello, go ahead, sir. Anyone, because reflective practice is beyond discussion, beyond clinical. Of course, reflective practice is what everyone needs to be doing. We all need to be doing that in our practice. We need to be learning from anything that go well, anything that go that way, we need to learn from it. We need to think about what we can do better, how we can keep improving our practices. Anyone, any reflection before we start? Time is running. The reflection is equally important as the discussion we are here to do today as well. Hello? Hello, can we hear me, please? Or I've been speaking to myself. Oh. Hello? Hello? Hello, can I confirm that we are still here together, please?
Hello, sir. Where are we, sir?
Yeah, all right, thank you. We might have a delay. I'm just interested in someone's reflection and we move on. Can somebody just, anything you've done recently? It could be even, it's not necessarily have to be what we've been discussing here. If there is anything you've done recently that you want us to learn from it, just share your reflection and let's move on. Reflective practice is really, really important for us. Yeah, anyone?
Hello?
Hello, ma. Good evening,
At
ma.
least, at least from, I've gained a lot of things, particularly me, a lot, but in particular, there's a patient that was referred like a week ago for ambulation, which ordinarily I'll have ambulated on Zimmer's frame, but there's a case of vascular disease, and I know that from what I have gained here, that hopping is not recommended for vascular conditions. So I went ahead and recommend that the patient be mobilized on wheelchair instead.
Wow, that's really fantastic. Thank you very much. Of course, I'm really happy for that. Being able to identify that vascular patients, national guidelines, good practice, safe practice, they are not meant to be open around. We need to keep them on frame as much as we can. We need to keep them on, maybe if they are major amputations, they might be needing wheelchair. something like that. If they need footwear, if there's just two amputations, giving those things to them, recommendations, send them to orthotics and prosthesis, P&O, or if it is orthotics, you call it in your settings, and sending them to them for offloading footwear if it's just two amputation. And if it is minor, if it is major amputations, we know no hoping, no frame, no crutches, nothing. It's just wheelchair until
And
if decision is made if they will be having what's it called, if they will be having leg prosthetic limbs or thereabout. So thank you very much. That's really lovely, good stuff. Thank you. So let's start today. Today is going to be on acute spinal cord injury, like I mentioned. So let's open up. So I think the first thing that is very relevant is about anatomy, about anatomy of the spinal cord. So, and I feel like knowing relevant anatomy is really very important in this patient group. This will help us to decide if this patient needs support from respiratory perspective. If this patient is also very important to establish their neurological level of injury. Even when it comes to what we need to be doing with them, with our treatment, is it going to be restorative or is it going to be compensatory? Is it have they got complete injuries or have they got incomplete or something like that is really very important. But the bitter part of it is just that anatomy and physiology of the spinal cord is really very complex. I can remember bad days in our basic medical. It's though a part of me enjoyed it, but it could really be really very scary. But let's just see how far we can go on this, just touching on the relevant anatomy, not bunch of things that are not relevant to our care, to our patient care. So I think, of course, we all know when we talk about anatomy and of the spinal cord, we know cervical, we've got 8 of these, thoracic, we've got 12, lumbar, we've got 5 of these, sacral is there, the coccyx is there as well. But if you look into the cross-sectional sections, the cross sections of the what do you call it, or the spinal cord, you're going to have something like this. So if we go back to our just to simplify these things, if we go back to our basic what do you call it now, basic biology, we know, for instance, if I'm touching, I don't know, can you guys see, because I'm not very sure, are you able to see me, please? Like the video, is it on?
We can
yes,
see you.
Yeah.
We can.
Yeah, all right, thank you. So if I'm touching something, let's say I'm touching an object, for instance, let's say I'm touching this, for instance, now. We know from our basic biology that, of course, some receptors will be stimulated in our hands that will be taken to the spinal cord, from sensory nerves, afferent nerves will be taken to the spinal cord. From the spinal cord, they go up into the eye center, into the brain. We know that from our basic biology. And the same thing happens, of course, the brain will also do some activities as well, send down some neurons, and those neurons will also fire and come down and, they go to the peripheral part, they come to our leg, we can walk, they come to our side, what do you call it? They come to our hand, we can use our hand for motor actions and all of those things. Yeah, we know all of these things from our basic biology. But the way I remember back in basic medical sciences, the way I normally think about these things, I think about these things in form of a rat. If you remember, like if you just picture a rat, maybe suppose this is a rat now. I know that a rat will normally get head, and they will also get a tail. So the head of rat is your cell bodies. I'm trying to describe a neurons now, a basic neurons. So the head is going to be cell body, and the tail is going to be axon. Forget about the other part of the neurons now. We are just touching on the part that are quite relevant to us that we need to remember as physio. Remember the head of rat, that is cell body. Remember the tail of rat, that is axon. Now, if you have bunch of axons that are going up and down in your spinal cord, what are you going to call them? You're going to call them tracts. If I show you in another picture, if you look onto the picture here, we are just trying to simplify these things. If you look onto the picture here, you can see, pretty excellence, please. Yeah, if you look into the picture here, you can see some structure running up, running down. Those are the tracts. Let me repeat. The tail of your rat is an axon. If you now have like a lot of those tails coming together, a lot of axon coming together, you're going to call them tract. And these tracts are structures that are going up and down in your spinal cord, if that makes sense. Right. So now, so again, so if you come back to the section of your spinal cord, suppose I divide this is spinal cord, and I make a section like this, I just divide it transversely. So you're going to have the front part of the spinal cord, and you're going to have the back part, the posterior part of the spinal cord. The front part, of course, anterior part, ventral part, those anatomical jargons. The posterior part, that's the behind part, right? Now, generally, if I need to do push and pull, if I need to push somebody, if I need to slap somebody, if I need to hit, if I need to do anything, those things are not coming from behind. I'm going to have to do them like frontally. I need to do them in the front. So that means I can always remember in my head that the front part of anatomy, the frontal part of the spinal cord will be much more related with the motor action. If that makes sense, pulling, pushing, eating, drinking, everything has to be in front. I'm facing the camera now. I'm not doing that from behind. I'm doing that in front. So these are motor actions. If that makes sense. Now, the behind part of the spinal cord, the posterior part of the spinal cord will be much more related with what do you call it? With much related with the sensory input. So if somebody is if you need to look at an object, visual sensations, or you are hearing me the way I'm speaking, auditory sensations, or if you are what is it now? Or if you are touching an object, let's say I'm touching an object, for instance, I'm making some nice smooth touch on somebody, for instance. Now, what is going to happen is, of course, that object is going to stimulate my mechanoreceptors on my hand, and those what is it now? The sensory nerves in my hands, they'll carry those information, they bring them into the spinal cord. How do they enter the spinal cord? They are not going to come into the spinal cord from the anterior part. They have to pass through the posterior part, if that makes sense. So what we are trying to say is the anterior part is the motor part. The posterior part is the sensory part. Now, let me pause a bit. I don't know, do we get that part, please? I'm just trying to find a way to simplify it. Do we get that part?
Yes,
Yes, sir.
Yes,
Yeah,
yes.
perfect. Yeah, perfect. Thank you. So now, so the other thing now we need to remember is this. Now we have mentioned that the anterior is more motor. Yeah, there is this a bit of sensory also that's also related with the anterior part. There are a lot of jargons upon jargons on this anatomy of spinal cord. But little things that is related with physio. In fact, few things that I often remember. Yeah. So now there is also some sensory part that are also related with the anterior part. Don't forget, anterior is more of motor, but there are some sensory part too. Sensory part like you can find tracts like spinothalamic. Spinothalamic has two parts. There is ventral spinothalamic and there is lateral spinothalamic. Now, the ventral part, just like the name, anterior part, anterior spinothalamic, that will also be in front. And also, if you look at the hands of these things now, two things in front, we got motor part, motor component. What is that motor component? Corticospinal tract. Corticospinal tract. Now, the other part you can find in the front that is more sensory related. This is what? Spinothalamic. But what part of spinothalamic? Anterior spinothalamic tract. If that makes sense. Now, of course, you've also got sideways, side things, side structures or your spinal cord. So you can find at the lateral part, you can find lateral spinothalamic, something like that. You can also, on the other side, you can also find, just like this picture here, you can find lateral corticospinal. And behind is majorly sensory. What is that sensory? Dorsal column. Now, this dorsal column, if I show you in another picture, this dorsal column here has two big, what do you call it? Big nerve, big bundles of nerve. Let me explain these things. Now, information that are coming from the leg up to the level of T6, those information from the leg, from lower abdomen, from the pelvic region, from your toes, everywhere, they will come down. For instance, if I'm stepping on something, my toes will pick it up. That sensory nerve will travel from my leg. They will go to the spinal cord. If something is rubbing on my, let's say on my thigh or my calf, for instance now, my sensory nerve will pick it up, they will pick it and they run straight into the spinal cord. If something is rubbing on my thigh, they will pick it up and those nerves will run up into my spinal cord. Now, at the level of 6-6, all this information from the toe, from the calf, from the thigh, from everything will come together and they form a big nerve at the level of T6. And that big nerve is called vesiculus gracilis. they form that big one. They call it vestibular gracilis. Now, anything above the level of C6, T6, maybe from the, if you are picking information is coming from my upper limb, from the upper abdomen, from the chest, from anywhere, those things, they will enter into the vesicular cuneators. Do we really need to remember this? Let me tell you what we need to remember. Let's go back so that I will not be speaking too much of anatomy. I don't want these things to be boring. Let's come back here. What do we have to remember? And why do we need to remember that? I'm going to tell you. Now, what do we need to remember as physio? Remember, spinal cord. They need something is in the anterior. Anterior, what is in the anterior? That's the frontal part. Motor actions, pulling, pushing, hitting, all those things, motor activities. And that motor activities are activities that are coming from the brain, that are going out, that are making like efferent actions, like activities, motor. But there is also a small part of sensory, the spinothalamic, like we mentioned. Posterior is more related with, what is it? Sensory. And what are the sensory you can find in posterior? You can find deep touch, two-point discrimination, proprioceptions, and all of those things. Those are the parts you can find at the posterior aspect. Why do we need to remember this? I will talk about that shortly. Let's continue. Does this thing make sense? Does it make sense? Do we pick anything from there, from that explanation?
Yeah.
Yes.
Yes.
Yeah, thank you. Can I get more response? Do we pick that, or anyone has any concern on that? Hello? Oh my God. Hello?
You say above the level of T6.
Yeah.
Which pathway do they pass through? Above the level of T6.
So above, we've got two pathways. Let me go back. That's not responding. We've got two pathways. We've got fasciculus gracilis and cuneators.
Yes.
Gracilis, just like if you remember our basic anatomy, we have a muscle in our leg that is called gracilis muscle. It's something like that. So the one for the leg will be gracilis.
Yes.
The one from the upper will be cuneators. The one above T6 will be cuneators. Then the one below T6 will be gracilis. If I really want to tell you, I'll start telling you there are first order neurons, second order. There are, what do you call all these things again? What runs medially between two of them, but we don't need all those things, honestly. We don't need all those things. We just focus on what is really important for patient care. We are no anatomists. We are physiotherapists. Know what is important to patient care. So let's move forward. All right. So now, I'm not going to talk about, maybe briefly, but I think I'm still going to talk about this later on, but I will skip all this slide. I will skip dermatons and this thing. So let's come back here to spinal cord injury. What are the causes of spinal cord injuries? Can we pop some of these things on the chat box? Yeah. What are the causes of spinal cord injuries? Like, what do we know? What can make somebody to have cord injuries? What are the injuries we know that can get somebody into these things? Yeah, can we put them in the chat
Road
box?
traffic accident.
Road traffic accident, perfect. Thank you very much, 100%. Yeah, can we get more? Yeah, thank you, people. Two more, yeah. Thank you, Peter. Excellent. Yeah, Peter Stella fall. Yeah, especially older adults, even with low velocity, they can fracture their spine. They can injure their skull. Yeah, road traffic accident. Peter Hamad. Thank you very much. Yeah, road traffic accident. Two more. Thank you, Peter. Yeah, excellent. Fall. Trauma. Yeah. Trauma could be penetrating injuries, stabbing injury, gunshot, all of those things. It could be gunshot, it could be infections. Thank you very much. You can have people with transverse myelitis, infections, anything. Yeah, thank you. Can we have more? Yeah, gunshot injuries. Yeah, gunshot. Thank you, PT Jane, PT Jamie. Thank you very much. Yeah. Degenerative diseases. Yeah, 100%. Yeah, thank you, PT Rita. Yeah, PT excellent. Assault is the code. Assault. Yeah, thank you very much. Yeah, great. These are fantastic. We all know these things. Yeah. Thank you very much. These are fun. Yeah, we can group them into two. We can have traumatic, we can have non-traumatic. And beyond trauma, sometimes you can have people with vascular disruptions. If there is maybe blockage, interruptions of blood supply to, for instance, now to some arteries like anterior spinal artery or posterior spinal artery, somebody can come up with cord injuries. Yeah, severe stenosis, somebody can come up. Congenital issues. These are non-traumatic things. Yeah, great. Yeah, you guys have mentioned infections. Yeah, great. Yeah, high bar sport, high contact sport. You can find people with that. people with divings, rugby and all of those things. Yeah, you can find people with that. Somebody have written something. Yeah, let me check. Yeah, TB. Thank you, Peter Hammer. TB. Yeah, congenital stuff or structural abnormalities. Yeah. All of these things can predispose somebody to cord injury. Yeah, we all know this. Thank you very much for that. Let's crack on. So now, what is our role as an healthcare professional? Now we are getting into our stuff now gradually. Let me drag this down. Just going on now. So what is our role as an healthcare practitioner? So our role as, um, our role comments when it comes to, establishing the level of injury. I think is as the first thing you and I, we need to start thinking about, even the medical team, we need to think about this. And when it comes to this, we, of course, the established, what is it now? The established standard that we can be aiming at to be using to our patients. Of course, we need to be thinking about ACL classifications and with ACL classifications. Of course, if you look at this, let me just say little things about this ACL classification, because sometimes, this is I know in our basic medical, or no, in our clinical years, we talk about this thing a lot, but have we ever seen people using this for patients? Have we also been, have we also had an input, or have we also seen people using this for patients in the past? So let's quickly talk about this thing briefly. So if you look at this picture on the screen, we can see, of course, with neuro patient, with SCI patient, what we are testing the sensory and we are testing the motor. So if you look at this, of course, first thing that people normally do is most people will normally test sensation for. And there are two sensations you are thinking about here. You are thinking about the light touch, and you are thinking about the pinprick sensation as well. So the pinprick, there is a particular thing people use. If you put it on maybe Google, something like that, you can look at the picture, neuro prick. So that part, so what you are testing both the sharp and the dull sensation with that pinprick, something like that. And oftentimes when it comes to sensory change, when it comes to sensation testing, so what people normally do is they will normally first test the region where they know, they are likely to have sensations. If they've not got any brain injury or anything, or head injury or anything, you can find people testing in their head, first of all, asking them, is this thing, can you feel it? Is it sharp? Is it dull? Something like that. Test it in their head, first of all, before you go to the other part of their body. And again, aside from that, another thing we also need to put in the consideration, because this is a very, 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 very impactful injury, that even somebody might not even come out of these things. So there are a lot of psychology, there are a lot of mental deterioration that is associated with this. So also put into the consideration of your patient if you are using these tools as well. If you are testing sensation, what I'm saying is, imagine I go to somebody's bedside and I start asking them, can you feel this? Can you feel that? Sometimes some patients it might even make them really feel like sad. So think about your patient, think about when is the appropriate time to do these things. Oftentimes, generally, people do neuro assessment maybe after 42 hours, because that might, you need, after 72 hours rather, because of some because at the early stage, because of edema, because of the need to stabilize them or things like that. So people tend to do it 72 hours, something like that. So the first thing you want to do, sensation testing. You are testing light touch and you are testing pinprick, like I mentioned. And when it comes to the scoring, if you have a look at this, when it comes to the scoring of the sensations, it's just 0 to 2. 2 means normal, 1 is abnormal, and 0 means there is no sensation at all. That is what you are doing here. So now, if you look at the picture here, you can see there is right part, you've got right and you've got left on these things here. So I'm testing both right, I'm testing left. So it's just, where are you testing? You are testing their dermatomes. On the picture here, we don't really have to cram this thing as well. On the picture, you've got areas where you are testing on the picture as well. Just go there. Even if somebody can print this thing and take it to their bedside and start doing it on their bedside, just go with a colleague. Somebody can be scoring it for you and you are testing. You are looking at what you are testing. If that makes sense. We've all had a lot of things to put in our brain. So now you can test those areas. So if they've got sensation too, if they've got this thing is 0, we put it there. That's it. And you come down here I don't know. Hello, are we still here? Can you see the picture clearly? I'm just trying to say little things about this.
Yes, we can.
Sorry, sir. Did you say 1 is normal and 2 is no sensation?
2 is normal. 2 is normal. 1 is abnormal. Then zero
Okay.
is no sensation. So
Okay.
now, if you are testing that,
Okay,
then you
thank you,
come.
sir.
All right, that's fine. Thank you. Then you come down. If you look at the box below here, you can find sensation right, left. So now, how do we score this thing now? If you look at, I've tried to put some numbers on these things. I see this one. No, let me check. I think it's this one. Now, I've tried to put some numbers on these things. C2, sensation 2, like 2, like for light touch, 2 for pinprick, 2, C3, same thing, C4, same thing. If you come to C7 now, for instance, you can see the light touch of this patient is 0 and the pinprick is 2. That is on the right. If you look at so what will be my neurological level for sensory testing for this patient? So what will be that? So if you check, that is going to be, so the least, if you check C6, 6 is the sensation is intact at the level of C6, but at the level of C7, for the light touch, this patient has got 0. And for the pinprick at C7, this patient has got, for the pinprick, this patient has got 2, which shows the sensation is intact. If I'm scoring these patients, I'm going to score on the level where the light touch is intact and the pinprick is also intact, if that makes sense. So for this patient now, for this patient group now, this patient is going to be scoring 6s for right sensations. If you go on to the left side here, you can see at the level of 6s again, this patient has got sensations intact, light touch 2, pinprick 2. So this patient will also be scoring 6s at the left side as well, if that makes sense. Now, for the motor part, if I need to do the motor part, there are 10 areas for the motor part. I know physio-wise, we test a lot of muscle group and these things, but there are 10 key points, key motor areas you need to test if you are texting for neuro patient, for spinal cord patient. So now, if you look at this thing is already on the scale. You can see, you can test C5, that's elbow flexors, C6, wrist extensors, elbow extensors, C7. You can find it there. What you need to text in the upper limb, you can find it there. What you need to be testing in the lower limb, you can find it there. For sensations, you can, I'm sorry, for motor, we are talking motor, yeah, you can find it there. What you need to be texting, you are texting 10 key areas, 10 muscle groups now. But again, if you look at this thing very well, you can see that from, you've only got to text finger abductions, which is T1 for the upper limb. That's the least motor, that's the last motor you are testing for the upper limb. And for the lower limb now, the lower thing, maybe the first thing you are testing here is L2. So what happened to other spinal level for for what is it now? For instance, now what happened to L1? That means I'm not testing L1. I might not necessarily need to test L1. If that makes sense to somebody. Now, this is also texting again now. For elbow flexors, now we are starting at C5. So what happened to C4, C, whatever now? You might not necessarily have to test that. That is what this thing is tentatively telling you. If that makes sense. So, and I'm going to score this thing as well. Whatever. So now, how do we score this thing? We are scoring this thing on our Oxford muscle grading. This thing 0 to 5. We all know how to do Oxford grading and these things. So 0 to 5. That's what we are grading this thing. And there is also a part here that says non-testable. Let's say, for instance, that somebody has got maybe above knee amputation. One of the leg is missing, for instance. So how do you test that? So that is not impacted. That is not secondary to their what is it like? Spinal cord injury. Maybe, for instance, somebody have had, maybe they have 10 years ago, they have above knee amputation. Now they have spinal cord injury 2 days ago. So if I want to test that region, that missing part, I will just say non-testable, empty. That's fine, and I will move away from that. If that makes sense. So look at this patient now. For these are our patients here. For the upper limb, hello, are we getting these things? Are we there? Is it making sense? Hello?
Yes, sir, we are together.
Okay, all right. Thank you. Thank you. So, all right, now, if you look at this upper limb now, for instance, now, we tested elbow extensors for these patients. They score 5. Finger flexors, they score 3. Finger abductions, which is T1, they score 3, yeah. So if I need to score this patient on the right side, So now, if I need to score them on the right side, so if, let's say, for instance, now, this patient had C7 is 5, which shows their motor function is intact at that level. Their elbow extensions is intact. But when you now test their finger flexors, they now score 3. So at what level do we think their motor activity is being impacted? So it's going to be at that level of C8, if that makes sense. And I will do the same thing on the other side too. These are practical things. I'm just trying to explain this thing in a very simple thing. These are practical things, honestly. So
Please, sir,
after
can
you've
you
done
come
this,
again? Can you come
okay,
again with this?
which one is it for the motor?
Yes, for the motor on the contract on the other side. Sorry, like you've tested for the left, then the right. I don't get what you just said now.
Okay.
You
So
don't need
what
to
I
test
said
what?
is, okay. So what I said is, if you look at the upper limb now, if you look at the upper limb on the right, so you've got
Yes.
the elbow flexors, wrist extensors, elbow extensors, all those things there. So for this our patient now, suppose we've had a patient now. So this patient, when we tested the elbow extensor, they scored 5. So when we tested the finger flexors, they scored 3. So when they score 5, that is intact. I'm not worried about that. So the
Yes.
least number is what I'm picking. So I'm picking, of course, I'm picking either 3 or 4. I'm picking 4, 3, 2, 1, 0. Down like that. If that makes sense. So now, so what I'm picking here is I'm picking C8 as my neurological
Point.
level here. Point. That's what I'm picking for this patient. And I will do that on the other side. Now, the other part here that's also important, and this depends on where you work, is testing the sacral tones and the sacral segment. It depends on, again, this also depends on our level of training. Are we trained to do sacral testings? I mean, checking inner tones and all of those things. Usually, even NHS, usually in some hospital, you might find doctor doing these things. Also in Nigeria as well, I don't know, sometimes you can find medical team running some of these things. Or sometimes it could also be a share to share something. It might be physio boy need to do sensation, do motor and sensory for the upper and lower limb, and the medical team can be running the inner tone, inner segment part of these things. If that makes sense. Now, so now how do we know? How do we know if somebody have come in with complete injury or if somebody have got incomplete injury? There are 3 criteria to know if somebody have got complete injury, and 3 of them must be present. Let me say this thing again. How do we know if somebody have got complete injury? There are 3 criteria, and the 3 criteria must be met. If one is okay, if one of them is okay, it makes it incomplete injury. Now, what are the 3 criteria? They are on these things. The first one here, if you look at here, voluntary inner contractions. Voluntary inner contractions is a criteria. So if they score, if they've got voluntary activities in their anus, then it automatically makes it incomplete injury. That means there are some sacral sparing and something like that. So now the other one here is deep inner pressure. So if this is also yes, incomplete injury. For this thing to be complete, that has to go no as well. And voluntary inner contraction also has to go no. Then the other thing is you then need to check the sensation in the S4, S5, the sacral region. The first 2, the voluntary inner and the pressure, this thing that you are doing, you are just testing the tones on these things. Usually, depending on where you work, depending on your competencies and this thing, you may have medical team doing all of these things. That part, that sacral part. It could be physios doing the upper limb sensation, motor and lower limb sensation. Then the medical team can run that one and we work together, share to share. You do your job, I do my job, and we establish our facts. It could be physio and doctor going to the bedside to do joint section with these things. I do my part, I step back, I let them do their own part. It could be depending on our working relationship, and which we need to be working together anyways. In an ideal environment, we need to be working together, something like that. So now, so those are the 3 criteria: your voluntary inner contractions, your deep inner pressure, and the sacral, what do you call it now? The sensations. Also, all those 3 things need to go no. They need to be off for you to deem somebody to be incomplete spinal cord injury. The other thing that I will speak about here, because of time, is the zone of partial preservations here. You can see it.
Sorry, sir. Which sensation at the sacral region? Is it S1, S2, or the whole sacral region?
It depends. I might just need to do maybe between S2 to S4 or something, S2 to S5 or something. I don't even know. Yeah. So that's it. So now, Thank you for that. Yeah.
I have question. So let's say this C7 for the motor aspect, we have 5. Then C8 we have 4. Then T1 we have 3. So where would be the neurological level?
I'll go with that 4. I'll go with that 4. Yeah.
Okay. 4.
I'll go with that 4 because what we are trying to see is the least, like just go with highest level that comes with lower how will I say it now? the highest level that comes with lower value is what you are picking. I don't know if that makes sense. So it's gonna be yeah, that's it.
Thank you.
Yeah. So like I mentioned, complete versus incomplete, you need to run those inner tone, sacral sensations, and if they are off, then that deem it to be complete injury. And indirectly, that is ACIA A. And that makes it to be ACIA A again. We know these things. You know, we've got ACIA A to E. E is normal. A is abnormal. A is complete injury. No motor, no sensory, no inner tone, nothing. And now, if you not, let's say, for instance, now you do sacral sensations, you do those things, and that is intact, that makes it incomplete injury. Now, if it is incomplete injury, we then need to check if it is B, if it is C, or if it is D. Let me repeat myself. Somebody I think I've got that here. Let me just go straight to it. Where is it? Yeah, this is it there. If somebody have got complete injury, no motor, no sensory, complete, that's A. If somebody have got B to D is incomplete. But what happened in B is sensory loss, it's sensory issue. That is what this patient has got. Now, the C is just motor. C and D are motor issue. But what happened in C is somebody have got muscle grade of 3, 3 or less than 3, something like that. But in D is you've got like 50% of your muscle below the level of injury, they've got muscle power more than 3 and above, something like that. I don't know if this thing makes sense. A is complete injury. B, again, we may not need to cram this thing. If it is not exam sake, if it is not sake of exam, it could just be, somebody is admitted, you got a referral, you pick them up again by yourself. When you screen their medical note, you pick them up. They've got injury. What is I might just go put it on Google, print out ACIA classification, and I go to their bedside. We have our heads to think about good things, honestly. So that's that about that. So the most important thing is not how well you can put all of these things in your brain. It is how well you can use these things for your patient. Let me say that again. If it's not exam, let's cram exam. If it is not exam, the most important thing is how well you are able to implement that thing for your patient. You can print it out and take it to their bedside and go and be doing it in their bedside, if that makes sense. And again, for the dermatome and myotome, it's there already. Just use it. And again, we need to understand again, dermatomes and all of these things, they change. Like not changing, like they vary depending on which distance you are using as well. Yeah, but that is not what we are discussing. Print ACIA classification, take it to their bedside, go and be doing it in their bedside, and work with your medical team for the anatomy and things. All right, let's move forward. All right, again, classification of injury, like we've mentioned, we can have complete. Complete is ACIA A, incomplete is B to D, and E is normal. That's that. You can also have another grading system. You can find Frankel, there are a lot of grading systems anyways. The difference between D and the ACIA classification is just that the C, what C is saying is non-functional. Yeah, it's just like that one too as well. But the D here is saying, they've got functional motor, not just muscle power is intact. How function are those muscles that are intact? That is what this man is saying about his own classification. Yeah, so now let's talk about incomplete syndrome now. Incomplete injury, what are the syndromes you can find? Let's talk about that. Yeah. And that is where those anatomy, those rubbish we were speaking in initially, those are where those things are important now. Like we mentioned, remember the other time we mentioned to ourselves the posterior part, sensory part. This is those are column modalities. Posterior part, those are column modalities. What are those things that are coming in? Your pain, your 2-point discrimination, your proprioceptions, they are coming to your posterior aspect. Okay, and in the anterior, there is motor actions. What is that again? Corticospinal. And there is also another, what is it? Another sensory part you've got as well. What is that one? can have anterior spinothalamic, and at the lateral again you have corticospinal and lateral spinothalamic. So anterior cord syndrome. So if based on my explanation so far, if somebody have got anterior cord, let me go back to this diagram, the first one. Yeah. If somebody have got anterior injury, let's say 2/3 of this side of this spinal cord is being lost now. Let's say anterior part, maybe there's an occlusion to the anterior artery or something like that. Let somebody have got anterior injury here. What will happen? Even from the explanation, motor part, don't forget anterior, motor, pulling, pushing, all those things, the motor activity will be disturbed. That's one. Don't forget again, there is also another thing that is also in the anterior part again, which is the sensory that we mentioned, the anterior spinothalamic, the light touch things, kind of things will also be affected. If this thing makes sense. If somebody have got posterior injury now, let's say posterior injury, occlusion to posterior artery, or whatever reasons or anything, somebody have got posterior injury now, what will be affected? What is coming from behind? Those things that are coming to the spinal cord, that are taking information from your peripheral part to the spinal cord. Pain. Sorry?
Sensory.
Yeah, sensory, like your pain, touch, sensations, 2-point discrimination, vibration, those things will be affected. These are simple. There are a lot of jargons around this thing, but at least what are the few things brain can pick and retain? Is what matters. Honestly, if somebody have got, let's say somebody have got half of this spinal cord is affected, like branchial cord, something like that. If half of this spinal cord is affected, now half of it is affected. Anterior, remember your anterior, there can be motor issue, yeah. Posterior is also affected, that half. Posterior is also affected, yeah. There will be proprioceptive problem, there will be vibration problem, there will be problem with pain. There is something at the lateral as well. There's also something at the lateral, all these lateral spinothalamic, all those things also be affected. That's how to remember this thing, honestly. Again, one thing I also need to tell you, that's also important, is this spinothalamic tract, they cross at the level of, don't run away. They cross at the level of spinal cord. If there's any concern with spinothalamic, it's going to be on the contralateral side. I think there's another thing to remember. In these things. All right, I will just move away from these things. I'll just move away from it. But let me just show us again, just like we've said. And again, remember what else to remember? Anterior cord. Okay, let me show you. Sorry. Yeah, central cord is the affectation is going to be more on the upper limb. Like you can see in the picture, yeah, it's going to be more in the upper limb. Okay. What is the other one again? I need to tell. Then anterior cord is going to be more in the lower limb. Well, of course, trunk will be affected and it's going to be in the lower limb. Just find a way to remember these things. Yeah. Does it make sense? Any question, any concern or anything? Yeah. Only if you want me to say a lot of anatomy here, then I can do that. Yeah. Any question, anything, but yeah. Hello? Can we continue?
Yes, sir, we can continue.
All right, thank you very much. Great. So we move away from all this syndrome. Yeah, there is also conus medullaris, there is Carda equina syndrome as well. There are also incomplete cord syndrome as well. So we need to also be aware of that. And sometimes clinically, sometimes conus medullaris and Carda equina is also sometimes it could be difficult to even differentiate them. It could be difficult. But again, like I mentioned, when it comes to patient care, what matters is what you are doing to your patient, what you're going to do. Of course, Carda equina syndrome is a red flag. We should be able, as physio, to identify that. You go to patient bedside, you can see no sensation in the inner region. There is what is the weakness in their lower limb. There is no sensation. You should be thinking about something. Leave them first. They need urgent MRI. They need this thing to rule out what is going on. All those things, we need to be able to clear it. Yeah. So that's that about that. So let's move on from all these things. Yeah. So we've got a case study we've got a patient to see together. So this patient is in one of our facility in Nigeria. So they had a road traffic collisions 2 days ago, no, they had a recent road traffic collisions maybe some hours ago. Unfortunately, this lady is just 49, and so she had a 6 spinal injury. So the ambulance team, they brought them into to our facility. So so this lady, they are currently now in our facility. So, but the question to first of all ask ourselves is, what do we think the ambulance crew should have done at the level of injury, like at the scene of the accident? What are maybe simple thing we can just think about in our head that, oh, when they had the collision, road traffic accident, when they, people that are walking around, our good Nigerians that are walking around, how, like normal thing now, let's first of all talk about normal thing. How well do we think they could have supported them? Or what are those good things we think that they could have done for them at the scene of that accident? Let's talk about that first. Because why I'm adding that to this is because, honestly speaking, when it comes to emergency response in our country, is really very poor. Is really very poor. And I feel these are a cogent area that everyone needs to be talking about. We have seen a lot that people will have accidents and people will just go there. Great, they want to assist them, they want to help them.
Treasure
They want to
on
assist
the
them.
fridges.
They want to assist them, they want to help them. People will go there. So this one person will carry the leg, one person will carry the head, one person will sit. We've even had one very popular person. No, I think was it this year or late last year, something like that. The person had an accident, and even the road, what do you call them now? Our FRC people, they even need to sit the person up in the car and all those kind of things. So I think this is a big area we need to educate ourselves. If somebody have an injury or if they have an accident, how do we move them? How do we carry them? What position do we put them? All those kind of, it might not necessarily be spinal cord injury. How do we just support them? I think that's the first thing. Yeah. Can I get some response in the chat box? So what do we think? People, like normal thing, first of all. Normal thing. Let's talk about normal thing first of all. What do we think people that are at the scene of the accident, either ambulance team, either people that are walking around, what are the necessary things they need to do for this patient? Yeah, thank you, PT Deborah. PT Deborah has written, immobilize the neck to prevent further injury. Great, very, yeah, excellent. Thank you for that. Yeah, PT, excellent. Right patient handling and transfer, 100%. Right patient handling. I love that choice of word. Right patient handling and transfer. Thank you very much. PT Ibrahim, stabilization and transfer, 100%. Thank you very much. Stabilizations. Yeah, we can also put it in the chat box. How do we stabilize them? Even the ambulance team, those our FR. I know Nigeria, we might not have some of these things, might be lacking in some areas of our country, but even our FRC, what beyond staying on the street and this thing, controlling traffic and this thing, they should have some emergency things to just support people and this thing. So what are the necessary things we just feel like, yeah, they can use to quickly stabilize people, not prevent abnormal movement or those kind of things. Can we put some of those in the chat box? Yeah, stabilization, transfer. Thank you, Peter Ibrahim, Peter Ahmad. Immobilize the patient neck during using flat. Yeah, you can use collar. Yeah, log rolling. Yeah, 100%. Yeah, safe manner handling, Deborah. Yeah, we are big on these things. We are physios. We are big. We should be teaching beyond. Yeah, and again, let me just say this. It's just by the way. Yeah. Now, we physios, we are doing content on social media these days. We are beyond showing infrared, beyond showing things. These are some of these things we can be showing people. How to move people, safe transfer of people from bed to chair, chair to bed, all those things, safe transfer, movement. We are big on manner handlings. Teach people how to safely move people. If we are moving people, maybe they've had accident or something, how do we move them? These are something we should be teaching people. We are very big on manner handling. Yeah, thank you very much, Peachy Deborah. I love that. Yeah, no upright position. Thank you, 100%. No, 100%. It's really very weird. Somebody had an impact. We go there and we just sit them up. Okay, that's dangerous. That's dangerous. That's really dangerous. No upright position. 100%. Yeah. Kola. A lot of names. Thank you very much. Thank you, PT Rita. Yeah, PT Mustafa. Yeah. Position the neck properly. Yeah, neck positioning really important. Yeah, avoid excessive movement. Yeah, We need to go outside. We need to be teaching our Nigerians, our fellow Nigerians. We need to be teaching them, those drivers, those anybody. This thing need to be taught to everybody. Basic life support, basic things. These emergency responses, all these things we need to be teaching people. The people need to be aware of this thing. Thank you very much, Peter Stella. Yeah, cervical block, anything that will stabilize the head, that will keep the head aligned, that will keep other spine aligned. Because we cannot tell at the scene of emergency or at the scene of accident, we cannot tell. Yeah, they've had head injury, they've had spine, they've broken their hand, they've broken this. We don't know. But what is the major thing is, don't just go there and be moving these people awkwardly. Stabilize them. Avoid excessive movement, like we've written here. Thank you very much, everyone. 100%. Perfect. So let's go into this thing. We'll come back to the rest of the question later. Let's go in. So at the scene of emergency, of course, we respect routine doctor ABC check. We have to be teaching people how to do these things. You don't have to go to school. You don't have to be a professor. You don't have to be physio. You don't have to be a medical doctor before you should be able to do basic airway check. Go there, check their airway, check their breathing and this thing. Yeah, we need to be teaching people to be doing this. Everybody needs to be trained. Common Nigerian on the street need to be trained to do this thing. Yeah, spinal stabilization, we have talked about that. Immobilizations, you have listed all of those things. No, and again, keep them flat. Keep them flat. Even if we are not sure whatever injury they have had, keep them flat. Don't sit them up. Do not sit them up. Either the patient is conscious, either they are unconscious or anything. Do not sit them up. It's very, very important. It's really important. It's really, really important. Keep them flat. We need to go on the street. We need those contents we are doing that we are using to get into people. We need to be echoing some of these things. It's really very important. And again, transfer them to trauma center. Transfer them to our teaching hospital. They need to go straight to the hospital. They need to get them straight to the hospital. Yeah, and again, people in the hospital as well. Yeah, we need to be that response, our emergency response. Yeah, within 24 hours, we need to stabilize people, whether medically or whatever things. We need to start thinking about all of these things. Yeah. All right. Maybe after that, initial medical management. Yeah, physios, doctors. We need to be thinking about. Yeah, let's do our ACUTE score. Of course, we are discussing spinal cord injury. Yeah, let's run our ACUTE score. Let's see what level they are. Let's look at the completeness of the injury. Is it complete? Is it incomplete? All of these things are really, really very important. All right. Thank you very much. Again, part of early management, you are thinking about catheterizations. You are thinking, of course, they need to do MRI for them, CT, all these things are important. And again, somebody that has sustained injury, again, they have sustained, don't forget, link this thing to our patient. Suppose this patient has got 6 injury now, for instance. We are, in terms of nutrition and gut movement or bowel movement or something now, they might need to do knee by mouth, of course. The medical team should be able to decide all of these things again because to prevent paralytic failures. Again, they need to be on thromboprophylactic agents, all of those things, neuroprotective agents. Of course, they are thinking about blood rest, collar support, traction, all of those things. And again, we're also thinking, are they going in for surgeries? Are they for conservative management? All of those things. Those initial medical management are really, really, really very important for this. All right. So, if they are in for non-operative management, of course, please, PT,
somebody will have carried it.
Selua, please. That is, yeah. So now, if they are in for non-operative management, you might find in the medical note, and again, as physio, if you are going in to see some of these patients, you also need to be clear. You also, of course, you need to clarify. Oh, are they for conservative management? Are they for surgical fixations or whatever things they want to do for them? If they are for non-operative management, you also need to check, of course. Some of them might even need to be on bed rest, flat bed rest. Even if they need to bring the bed up, it might not be maybe more than 30 degrees or something like that. You might need to clarify for how many this thing. Some you can find people 6 weeks, 8 weeks or something. Depending on where you work, depending on protocols. And another thing I also like to say here is, in our country, in Nigeria, we need good pathways. There are a lot of patients that are mismanaged, a lot of SCI patients that are mismanaged. We need clear pathways. All the MDTs need to come together. We need guidelines. Yeah, if somebody have come with this injury, what are we going to do with them? We stabilize them, we put them on, we start them, we commend them on these pathways. We commend them on this pathway. Physio, you know your clear job, you know what you are doing with every other members of the team, the nutritionists, the dietitians, the medical team, everybody, they know their job. They are doing their job. We need clear pathways. We need clear, because a lot, you need psychologists, clinical psychologists, because a lot is in place for these things. Unfortunately, when I was preparing the slide, when I was going through some of our articles, our lovely prof have written in Nigeria, most of what I realized is most of these patients, they end up dying. Most of them, they end up dying. Either they die of respiratory issues, or either they die of pressure sore or something, integumentary damage, infections. So this shows that majority of these patients are not being managed well. They are not being managed well. All right, so again, you might find people that will be for operation, surgical operations, they might fix their spine or whatever things. Again, even if they've been back from theater, from what is it now? From the theater now, you also need to confirm. Do they still need cola? Do they need this? Do they need TLSO to stabilize their spine? Think about these things. Think as physio, you need to ask those questions. Read their operative notes, ask those questions as well. Oh, do they still need to be on bed rest? Do we need to ask those questions? They are really, really very important. Yeah. They're really, really, really very important that we do that. Yeah. So now we go back to our question now. Or we go back to those questions. The question again, I go backward. Yeah. So now we have talked about the scene of accident. So the other thing is, what do you need to know before you assess this patient? This is our patient, 47-year-old lady. She had 6/6 spinal injury. So we are talking about the scene of accident, how this patient should be moved and all of those things. Now she's in the hospital now. You are the physio in charge. So now you are the one leading the ward grant. So we are with you now. So what do you need to know before you assess this patient? Let's either you are speaking with the doctor, what do you want to hand over from the, what handover do you want to get from the nursing staff? What handover do you want to get from the medical team? If you are reading the note, what handover do you want to, what are you picking up from the note? What do you really need to know before you assess this patient? Can we talk about that? Let me just, I'm reading the chat box now. Yeah, okay, yeah, thank you, Peter Selva, thank you for that. So now, so I'm reading the chat box now. So now we have talked about scene of accident. Now we are going in to see this patient. What do we really want to know? Either through handovers, either through reading notes, either through verbally speaking to the medical team or nursing staff or anything. Is there anything we'd like to know? Yeah, let's pop that. Yeah, bleeding. Yeah. We want to know if there is any case of bleeding. Yeah, we want to know if there is fracture. Yeah, what level of the injury, what fracture anywhere. Yeah. Thank you very much. Yeah, Peter Stella, great. We want to know if they've had what is that? Yeah, if they've had scan, if they've been scanned, CT scan, MRI, what do they say? Yeah, we want to know those things. Perfect. Yeah, we want to know if there is any case of open wounds or whatever. Yeah, we want to know if there is fracture rates. Yeah, because there might be associated injuries. Some people might fracture their tibia, their humerus with it. Some people might fracture their ankle with it. Some people might, some people might have a flare rate with whatever injury they've had. And we want to really know all of these things. Yeah, thank you very much, everyone. Keep popping in. Yeah, what else? Yeah, we want to know. Yeah, great. Their hubs, their observations. Are they on oxygen at the moment? Are they? Yeah, great. Yeah, mode of accident. Yeah, we want to know, is it high velocity accident? Is it low impact or anything? We want to know. Yeah, great. Yeah, Selua, yeah, great. Of course, the oxygen saturation, yeah, we need to be checking the SAT with probe, with pulse oximeter. Yeah, great. We need to know whether it's complete or incomplete injury. Yeah, great. It could even be maybe in our facility, maybe it is the medical team that are leading the Asia classification that are doing those things, are checking the MRI, or of course, physios can also be doing those things as well. Of course, but from their note, from a radiological report, we can also see, is it complete, is it incomplete, what are their line of thinking? Yeah, we are thinking about this. And thank you, Piti Jami. Yeah, vital signs, stability. Yeah, we are looking at those things. Their hopes at the moment, are they stable? Are they on respiratory arrest or anything? Yeah, you are looking at their blood as well. Yeah, HB important, great. There might be bleeding, the scene of incident. Some people might be on blood transfusion. Yeah, it could be any. Yeah, great. Yeah, great. Keep popping these things. Yeah, great. Yeah, past medical history, great. Past medical history also important. Yeah, it's also important. We know. Yeah, we want to know if there is anything that we can link up with whatever their presentation is. Great platelet level, yeah, just to know if there is no, if there's no bleeding anywhere. ABGs, blood gas, yeah, all of these things are quite very, very relevant because we are going in to see them. We need to formulate those clinical reasons before we see them. Yeah, perfect. 100%. Thank you very much, everyone. I'm impressed. Very impressed. Yeah. So let's go. So at the same what do I want to know? I've written some things here. Of course, we've discussed some of the mechanism of the injury. Is it high velocity? Is it low impact? Or blah, blah, blah. We want to know their injury. Is it stable injury? Is it unstable injury? You want to know. And again, they could have document. Oh, are they for conservative management? Are they having operations? How should we be moving them, log rolling them? You know, all these things. We need to be checking them. Do they need polar? Do they need braces? Do they need TLSO? Anything? We need to be checking those things. Medical plan, like I mentioned, surgeries, procedure, neurological level. Maybe the doctor they've done ACIA classification, all these kind they've had, everything. We need to be checking those things before we go in. Their hubs, their vitals, their blood. Not just read their notes, their medical distance. You just need to check the nursing chart, their blood pressure, their heart rate, their everything, saturation, everything. Check all of those things. Look at the blood. Look at the blood. Look at everything before you go in. Formulate your clinical reasoning. Have a clear plan. Have a clear plan before you go to their bedside. Clear plan. Be prepared. Now you can also get to the bedside and things might have. Then you just adjust. You just adjust. But have a clear plan before you go to their bedside. Great. Perfect. Well done, everyone. Yeah. So now I go back to the question again for this patient. What are your first priority for your assessment? Now we have formulated a lot of big clinical reasonings before we go to their bedside. But now we are at their bedside. What is your first priority for assessment? You are the physio in charge. You are the one leading our ward round. So what is the first thing? Suppose this is a patient now, 6 spinal injury. So what is your first priority for assessing this patient? What is our first priority? By the time you get to their bedside, what is the first thing we need to be assessing for? Yeah, can I have that in the chat box and why? Put the reason there. I think it's important we talk about the reason too. This is why we are experts. This is why we are physios. We do things based on reasoning. We do things based on reasoning, based on needs and in order of priority. So what is the first thing we need to be assessing in this patient? Not just random things, but if 3, 4, 5, 7 great physios have gone to the bedside of this patient, what is the first thing we all need to be checking first? First thing first. Yeah. I will stay there. Please. Hello.
We are with you, sir.
All right.
We are with you, sir.
All right. Thank you. Appreciate it. So what is the first thing? What is the first priority for our assessment in this patient and why? This is why we are physio. Yeah. Let me check. Somebody has written something. Let's check. Oxygen saturation. That's PT Stella. Why do you say oxygen saturation? Why oxygen saturation? Yeah. There is no right or wrong. It's all about clinical reasonings. Yeah. If I think it's this one, yeah, I go for it. It's my reasoning. Yeah. Great. Yeah. Sensation to confirm level of injury. That's PT Hemler. Yeah. PT Richard breathing pattern because of phoenicians now, our phrenic nerves. Okay, yeah. That's Pitirita. Yeah, Pitirita is saying we need to be checking our breathing pattern first. Yeah. Let's have different reasonings. Let's just see different reasonings. Yeah. Thank you for that, Pitirita. Yeah. Because of phrenic nerve. Yeah. Okay. Okay. Can we have more reasonings? Why are we checking? Well, what is the first thing? The first thing first. What is our first concern in this patient with 6 spinal injury? Yeah, bed positioning. Yeah, that's PT Anthony. Yeah, thank you for that. Great. All right. Let's have more reasonings. Physios, please speak. This is our patients. They need us. We are at their bedside. What is the first thing we need to be checking in this patient? First thing first, what are we checking for? Of course, we're going to check a lot of things with this patient. We're going to have a lot of input in this patient. But what is the first thing first and why? Consciousness level of this patient, great, brilliant stuff. That's pretty excellent. Yeah, of course, like I said, there's no right or wrong in these things. It's all about listening. It's all about, Pitijami level of neurological deficit. Great, thank you very much for that contribution. Yeah. Can we have more physios on board? More physios, more lovely physios on board. Positioning, PT Stella, great. Thank you very much. Of course, we need to be checking their position as well. And sometimes if they are in awkward position, they are in wet positions, we need to give that expert, that professional advice, that expert advice. We need to be giving them those advice. We need to talk to the medical team, speak to the consultants, speak to the nursing staff, speak to everybody and say, look, this is the best position for this patient. And let them know your reasoning. Give them that sound clinical reasonings. And we put the patient in that position. We put it, if they've got bedside mobility board or something, we are board at the bedside, put it there, document it there, make it clearly, please. Keep this patient in this position. We're still going to talk about position. Position is really, really very important for this patient. If you get the positioning wrong, it's going to impact this patient. We need to talk about that. Thank you, PT Stella, for that. Yeah. So what is first thing first? Can we have more physio on board? The more we participate, the more this thing becomes interesting. The more we share our experience, our wealth of knowledge, the more it becomes interesting. Yeah. So please be involved in this thing. This is our patient. We need to do something. We need to think. We need to reason together. We need to put our brain together. Yeah. Any more contributions? So let's look at this thing together then. So first thing first, I would say respiratory. Yeah, great. People have mentioned consciousness, and of course, we need to check those things. But in the long run, I would say fast and high on their respiratory parameters. Somebody have sustained 60. Somebody have let me look at the chat before let me see what people have written. Yeah, muscle power, skin sensation, pressure sore, using catheter and diapers. Yeah, these are great things. Yeah. I think spinal cord injury is really, really a big domain. Even when it comes to all these diaper, pressure sore management. Pressure sore management alone is a big topic. Urinary management again alone is a big topic. Integumentary management alone is just a big one. We cannot finish this. That's the PT cellular, check their consciousness level, use GCS. Yeah, great stuff. Good stuff. So now, why did I say cast an eye on their respiratory management? Generally speaking, before I open that, let me first say this first of all. And please, I'm begging us. We are lovely physios. Yeah. For every SCI patient, every SCI patient, let me put it like this. Either because of the injury they've got, or either because of prolonged bed rest, or either because of the sedentary, they will be more restricted to bed, there is high chance for them that they will develop respiratory compromise. The chance is there. Especially if you've got patients that the injury is above T6. I'm going to show us some this thing to make, I don't want it to be abstract. I'm going to show us some chart very soon. If you've got a patient that the injury is above T6, that patient is at high risk of respiratory compromise. As physio, let me emphasize that. As physios that we are, we need to support their respiratory parameters. We need to cast an eye on that. In fact, complete prophylactic treatment. Some of them do not really have to come with respiratory issues before we start treating before we start doing some respiratory stuff with them. Let me say this thing again. If you've got somebody with this, that the injury is above TC, commence your prophylactic respiratory treatment. I'm going to show us this thing. We're going to talk about this thing. And generally, if somebody have got T12, let me put this thing like this. I don't want it to be complex. If somebody have got above T12, if the injury is above T12, they have high chance that their respiratory apparatus or their respiratory mechanics or whatever will be affected. The chance is there. Now, if you now go further up, let's say 6 and above, then somebody is now at high risk. Let me say this thing again. If the injury is above T12, they've had a chance that their respiratory mechanics will be affected. If somebody is now above T6, the chance is really, really high that they will develop respiratory compromise. Why these things we are saying? Let me go back. Let me just move forward and show you something here. Now, look at this thing. Please look at this table together. Again. Let me say this. We don't have to cram these things again. Oh, this one supplies C7 to this. That is not important as being able to use these things to formulate a good treatment plan to your patient. It could be maybe in our various offices. We just have that chart. You print it out, you paste it on the wall. Immediately we need to do, if we have patient that we need to utilize that info, I can pick it up and go to the website and look at their note and use this thing I've pasted on the wall and use that to formulate my reasoning. I do not have to cram these things. Your cramming does not make you a better physio. What makes you a better physio is that thing, that input, being able to interpret these things, being able to affect the life of patients. That is what matters. I know for the sake of the exam, if we are students, hey, what is this one? Yeah, but classroom is different from life. It's different from handling life. If we need to affect life, we might not necessarily need to cram these things. What matters is being able to use that reasoning to impact your patient. Now, our patient have got, hello, please, can you hear me clearly? Are we still there? Just double checking.
Yeah.
Are we still there, please?
We can hear you, sir. We can hear you, sir.
All right, thank you very much.
But there's background noise.
Thank you. So if our patient have got 6/6 injury, don't forget our patient have got 6/6 injury. Look at diaphragm. We all know from our basic anatomy that diaphragm is a big muscles of respiratory. 6/6. This patient, what nerve supplies diaphragm? Somebody mentioned phrenic nerve the other time. I think it is Stella or something. Somebody mentioned phrenic nerve. Phrenic nerve is just C3, C4, C5. Okay? But our patient has got 6/6 injury. That means the diaphragm will be working well. If that makes sense, diaphragm will be working. In our patient, the diaphragm is preserved. That phrenic nerve, that your motor nerve for diaphragm is preserved. C3, C4, C5 is preserved. Diaphragm will be working fine. Beyond diaphragm, if you have a think about your respiratory mechanics. If I take in deep breath, for instance, if I need to breathe now, don't forget breathing. Respiratory is just inspiration and expiration, something like that. So my diaphragm needs to descend. Boy's law. My diaphragm needs to descend. I need large space in my thorax. That's volume. The volume in the thorax will go up. The pressure will drop. Don't let me go that way. If I need to breathe, I don't want it to be complex. If I need to breathe in, my diaphragm will descend down. There'll be more space in the thorax for here to fill in, so that lungs can become bigger and here can fill in into those lungs. That's how it works, right? And again, for my thorax to be well stabilized, I need some muscles in the thorax, intercostal muscles, blah, blah, blah. Those muscles need to be active as well. They need to be working. Yeah? What are those muscles here? Intercostal. You can see intercostal here. What supplies intercostal? T1 to T11. We are coming. Now, also, that is inspiration, right? How about and again, if somebody needs to do maybe labored breathing now, or maybe you are running now, you need some accessory muscles of inspiration to kick in, something like that. So what are those accessory muscles? You need scalene muscles, the muscle in your neck, you need sternocleidomastoid. So you can even need P major, pectoralis major muscles, and all of those things. So if you look at the innervations to the scalene muscle here, that's C3 to T8. Pectoralis is C5 to T1. You don't have to cram it like I mentioned. So these are muscles of inspirations. Diaphragm, comfort muscles of inspirations. You need your diaphragm. You can also need some accessory muscles like scalene, the muscles in your neck, sternocleidomastoid, big muscles in your chest, pectoralis major. You can need those ones, right? Now, if you need to expire, don't forget normal breathing, tidal breathing, normal breathing, relaxed breathing that you and I are doing at the moment. It's just the diaphragm going down passively, and what is it again? So we are breathing out using our expiratory muscles. What are the expiratory muscles? We need our abdominal muscles, abdomen. We need our abdomen to be able to contract. What do we need again? And again, we still gonna need our intercostals and all of those things again. Let me repeat these things. I think it's getting complex. Let me repeat it. Diaphragm. Our patient have 6-6 injury. Diaphragm is a big muscle for inspiration. Diaphragm is paired. Diaphragm is working well. But I know again that intercostal is also important for breathing. Somebody has injury at 6-6. Somebody has injury at 6-6 level. So what happened? That means innervation to the intercostal is affected. I don't know if this thing makes sense to somebody. Intercostal muscle now is affected. That means the chance is there when this patient is breathing. Even if the fact that diaphragm is working well, when this patient is breathing, the normal breathing is by the time you breathe in, you want the thoracic region to move up and outward. Remember when we are talking about rib this thing last time, I talked about pump handle movement, I talked about bucket handle movement and those things. That is normal movement of the thorax, right? But what is likely to be happening in this patient is by the time they breathe in, instead of thorax to be rising up, thorax might be shocking in during inspiration, if that makes sense. On expiration, you need abdominal muscles to be moving. You need abdominal muscle to contract on expiration. But this patient has injury at C6. That means the abdominal region is also affected. Oh my God. I don't know if this thing is making sense. The abdominal region is also affected in this. That means this patient will not be able to actively contract the abdominal muscles. So this patient will not be able to actively contract their abdominal muscle. Now, and again, don't forget, even if you need to clear your airway, you will still need your abdominal muscle. Again, this patient will also struggle to clear their airway because the innervation to the abdominal muscle is also impacted. If this thing makes sense to somebody. So that means now, even for the fact that this patient 6 level now, their diaphragm is working. I know if I go to their bedside, there might be some paradoxical, that is the English, paradoxical movement of the respiratory mechanics. There might be shocking in of thorax on inspiration. There might be rising of abdomen. Instead of abdomen to be contracting, the abdomen may be doing the opposite on expiration. If that makes sense. That means, again, when it comes to, do we now think in these patients now, do we now think they will be able to get that big breath that everybody, normal person should be getting when they breathe in? Do we think this patient will be able to get in that? Or do we think this patient will be able to fill in their air into their lungs properly? Please, can I just check? Can I just get yes or no in the chat box?
No, they will not.
They will not be able to get it. Because the thorax will not be able to move outward and upward during inspiration because those intercostal muscles are not working perfectly well. And again, think about coughing again. This patient, for somebody to cough, we have explained mechanism of coughing before. You need 3 things: inspirations, glottis closure, and you need your what? You need expiratory flow, expirations to be able to clear your airway. On inspirations, this patient is not filling that lung perfectly well. If your patient is not building up the pressure very well in the thorax, that will impact the glottis closure. And again, when it comes to expiration, clearing the airway, this patient will also struggle to do that again because of the level of injury they have. This is how we need to be thinking for our patient. If you've got a spinal cord patient, oh, they said they have injury at let's say you have somebody now. Oh, okay, let me ask us a question now. If suppose we've got somebody, they have injury at the level of C4. So what, using this chart now, look at this. You don't have to cram anything. Look at this table here. And can we just figure out respiratory wise, what do we think will be going on with this patient? They have injury at C4. Forget about our patient now, 6-6 now. Suppose somebody have had injury at C4. So what are we thinking about? What do we think will be affected? If you want to speak, you can speak. If you want to put it in chat box, put it in chat box.
So I think the patient will be having some respiratory difficulties.
Yeah. Good.
The diaphragm will be affected.
Sorry.
The diaphragm will be affected.
Yeah, the diaphragm will be affected because part of the innervation to the diaphragm is your C4. The diaphragm will be affected. Again, if you look at the scalene muscles here, the muscles in the neck, the upper shoulder, and all of these things. So what will happen to C4? So the innervation to the scalene muscles between C3 to C8. Again, there will be partial innervations, partial movement of the scalene muscles. So muscle group are not working. There will be problem with breathing. There will be problem with breathing. This is how we think about some of these patients. Now, and again, this is what, let me quickly read what people have written in the chat box. Yeah, a lot will be wrong, cause diaphragm will be affected, all the muscles, yeah. In fact, again, oxygen requirement. Before you know, they will start, the oxygen requirement might be going up. Some of them, work of breathing, you are thinking about this thing. Even before you go see your patient, you are thinking about work of breathing. They'll be struggling to breathe. Paradoxical movement of the chest, of the chest, what do you call it now? Or of the chest wall. If this thing, this is, thank you, PT Ablasis. This is what we are thinking about before we go to the bedside. So what I'm advising here is, if we got any patient, they've got injury, chat them first of all. Look at it, because you know, big thing you need to be thinking about is respiration. Don't leave out that respiration, and now focus on everything is not. I know other areas are also equally important, but think about these first of really important. Now I ask us another question: if you've got somebody, they've had injury at the level of L1, what do we think? What do we think might be going on with them? L1. Yeah, thank you very much, Peter Ablaziz. Mucor retentions, increase cost of bleeding, perfect. Great job. Come to that mucor again. Good thing. There's a part I'll still discuss later on about autonomic, what do you call it, dysfunctions or something like that. Those things also make their mucor production even more than normal. So that is the reason why you need to do it. If you don't check, some of them might have respiratory failure or something. So we need to be checking them. It's really important. So now, I've got a question. If you've got a patient, they've had injury at the level of L1, so what do we think respiratory-wise? What do we think? Are we worried? Are you not worried? Yeah? Have a look at this thing. Yeah? Yeah, PT Grace, for the level of L1, respiratory biomechanics will be spared. Yeah, how do you know that? Look at the chart box. Look at it. L1, you spared T6, your T12, your abdominal region is spared, your diaphragm is spared. Great. I might not need to commence prophylactic treatment with them. I might not need to do so. But if you, like I mentioned the other time, if you've got somebody, their injury is above T12, think about their respiratory issues. Especially if their injury is above T6, commence prophylactic treatment. Commence that prophylactic treatment. Really, really very important. If this thing makes sense. Yeah. Some other thing before I leave this part. Some other thing. I've got another question for us. Yeah. I've got another question. That question just kicking in my head now. Somebody mentioned positioning the other time. What do we think is the best position for this patient? Because this is another key area that again and again, some patients have died because of positioning. Some patients have died because of basic things that are not put in place, like positioning. So what do we think is the best position for this patient and why? Yeah. If you want to speak, open your mic. It's just clinical discussion. We are experts. We are lovely physios, excellent physios. Yeah. If you want to put it in the chat box, put it in the chat box. What do we think is the best position for this patient? Yeah. Yeah. And with us. Hello. All right. Let's check what people have written. Yeah, Tuturucha, outline, it is cellular, semi-fowler. Yeah, I can see. Yeah. It is Jamil, supine line. Yeah. Oh, Pity, I didn't look at the question again. My question is, what is the best position for somebody that sustained an acute spinal injury? Let's say now our patient have got 6 injury. So what position do we think is the best for this patient and why? Yeah, the patient should be stabilized with collar, place 30 degree. Yeah, place 30 degree on the bed. Pitystellar, flat position, pity ablasis, any position that will make gravity to be of assistance. All right, we've got diversity in opinion. Yeah, great. This is interesting, very interesting. Yeah, so keep popping your opinion on the chat box. Yeah, pop your opinions in the chat box. Yeah, great. We've got diversity in opinion, and this is nice. This is nice. Nobody is wrong. Nobody is right. We are just sharing knowledge. Yeah. If you've got patient 6 injury, for instance, in our patient, so what is the best position for them? Because again, like I mentioned, that position is really, really key for this patient. And some of people have died because of this position, because the position is not optimized. What position do we like to put this patient? What position and why? Can I have some reasoning? Can we have some reasoning? Like Peter Ablasis now, he has justified his reasoning. Yeah, because of gravity. Yeah, Pityritta, outline to aid respiration and stabilization. That's from Pityritta. Yeah, and we have few more reasoning. Few more reasoning. Yeah. All right. Yeah, supine with cervical spine in neutral alignment to protect the spinal cord. That's PT. I don't know how to pronounce it. I'm sorry. Tanis or James. I'm sorry. Yeah, supine line, cervical spine in neutral alignment to protect the spinal cord. Great job. Thank you very much for that contribution. Yeah. Yeah. Can we have more contributions? Yeah, that is why we are here. We are just sharing knowledge, yeah, to improve our patient care. All right. Thank you very much, everyone. They are lovely contributions. But I'm going to say, generally speaking, let me read this last one. Yeah, flat position, supine line with cervical spine, bed should be tilted 30 degrees to aid work of breathing. Great, excellent stuff. Supine position as body weight is equally distributed, flat at the acute stage, but chronic, semi-fowler, great, that's pitystellar, flat, pitygamy, flat line to maintain postural reduction. Great stuff. Thank you very much, everyone. Yeah, first thing first, we need to be aware of position. We need to be aware of position. I know from physio point of view, we like our patients to be upright. Other patient group, we like them to be upright. We like them, if you remember in every other seminar that we've had, we like to say, go to that. Don't forget this thing I used to say. Oh, some patient standing is better than somebody sitting. Somebody sitting is better than somebody's, what is it now? It's semi-fowler in bed. Somebody semi-fowler in bed is better than somebody in supine position. Great stuff, lovely stuff. And there are reasons for that. Every FRC will go up, your tidal volume will be okay, your this thing, great. Those are great for other patient groups. But in spinal cord injury patient, we like to keep them flat. Keep them flat. Acute phase, keep them flat. Why? The reason is this. Let's explain. Respiratory wise, we know that if somebody is lying flat, we know that the what is it now? The abdominal, the abdominal content and everything, they will have impact on the diaphragm, right? They will further push the diaphragm upward. Now, again, remember somebody that have got spinal cord injury, like this our patient, 6 injury. We know that they don't have any tone in their abdomen. They've not got any muscle tone in their abdomen. So that means the viscera in the abdomen, what have you got in the abdomen? The kidney, the liver, and those viscera in the abdomen, they will push the diaphragm up. If they push the diaphragm up, I would say that is a good thing for diaphragm at that position, because diaphragm, don't forget, diaphragm is working well. Okay, now that is really good for diaphragm. That is just like you are stimulating the diaphragm. Diaphragm can easily go up. They can also come down. Again, that would be great for that patient in that particular period of time to be able to maximize. Because now what you are saying is you are using the viscera to be acting on the diaphragm as supposed to be tone, like abdominal tone that the patient is supposed to be using normally. But now the patient have not got any tone in the abdomen. And again, if you go back to evidences have also shown if you do FVC, forced vital capacity. Forced vital capacity is just the amount of air you are able to get in out of your lungs after you've taken a big breath. That's vital capacity. If you check their FVC, which is also important, one thing, I'm still going to talk about that. One thing we need to be checking in this patient group. If you check the FVC is likely to improve in supine position about 6% or thereabout, 5 to 6% or thereabout. That is what evidences have shown in this patient group. And again, think about it. If you set this patient up, I'm still going to talk about autonomic dysfunction. Leave those one out for now. It's also a good reason, anyways, why this patient needs to be lying flat, why this patient needs to be flat. But leave those one out of this thing for now. If you keep this patient up, don't forget these people, they've not got any tone in the abdomen. So what is going to happen? Just think about it. Somebody have not got any tone in the abdomen. So what is going to happen to they've not got any tone in the abdomen, the pelvic floor, anything like that. Let's say it's a complete injury, they've not got any tone in the all these levator and all those, they've not got any tone. The viscera will just drop. Even diaphragm will find it really, really difficult to come down, to really push, have a big push on those things. And again, if your diaphragm even finally come down, to even go up again with the tone, with the weakness, with the distension of the abdomen, it's going to be difficult for you. I don't know if this thing is making sense. So the big part of these things we are trying to say here is that for this kind of patient group, keep them flat. If you go to the bedside at the acute phase and you find this patient being sat up in bed or something like that, or somebody is just trying to move them anyhow, speak to them, communicate your reasoning to them. It's really, really very important with this patient group, if that makes sense. If you look at the picture I put here, for instance, again now, or even though this picture is saying why maybe with time you find people retaining CO2, and I think it's something we can also relate to if you've been part of our discussion for a long period of time. Something you can relate, where these people can have they can retain CO2. I think it's very clear. We've indirectly spoke about that today, because now it's only diaphragm that is working. The abdominal muscles now is not working. They will find it hard to blow out here, to blow out CO2, to puff out CO2 in their lungs. Before you know, they will start retaining CO2. Generally speaking, you might find people with type 2 respiratory failure or something like that. That is when we need to be checking their respiratory system. I don't know if this thing is making sense. All right, let's move away from here.
Sorry, so again, please, sir. Please, can I ask a question?
Go ahead.
How we manage a patient that has paradoxical breathing?
Right, great. For a patient that have paradoxical breathing, honestly speaking, I'm still going to talk about this thing. FVC is one of those things you will quickly want to do with them. If you do FVC with them, and again, somebody that have paradoxical breathing, before you know, because of their chest movement, they are struggling to get here in, they are struggling, before you know, their pump might fail. The pump fail. What is going to happen? Their chest is not moving again. They're going to die. They're going to die. If their pump fail, they will start retaining CO2. They might go into respiratory arrest, coma, and die. So that might be a sign that, we need to ventilate this patient. We need to escalate to medical team. If you find a patient, spinal cord injury patient, they are really working hard. That paradoxical breathing is there. They are working hard. Some of them might need to be intubated. Some of them might need to go on NIV, for instance, to offload their breathing. So we need something that can take away their breathing, take away their effort of breathing, to make breathing much more easy for them. Did I answer your question, Ma?
Thank you very much, sir. Yes, sir.
All right, thank you very much. So we need to, by the time we go to the patient bedside, we need to be able to identify these things. You find somebody chest wall is shocking in during inspiration, all right? And you find, you find abdomen doing the opposite on expirations. What do you want to do? Please escalate to me. And they are really working hard. You can see that this patient is working. Escalate to the medical team. Escalate to them immediately. Otherwise, that pump might start failing. They may start retaining CO2 and they might die. And that's the end. So we need to be able to identify that. Because of time, I will not sit with this picture I've put here to be able to explain some of these things, but I won't talk about this because of time. But I think we can still relate some of these things where somebody can have cough reflex. I think we have spoken about that today. If somebody has got cough reflex, what happens? Secretion will start building up in their chest. And remember, this spinal cord injury has some disruptions to autonomic systems, sympathetic, parasympathetic system. Even the mucous secretion becomes much more than normal. So the secretion will start building up in their chest. And again, you know that their cough reflex is done now. And they are struggling with expiration, like in our patient, 6 injury, for instance, or somebody with 6 or above T6 injury, for instance, now. And before you know, chest infection, pneumonia building up in their chest. And again, FRC, functional residual capacity, again, we also drop. Why? And again, remember, let's say somebody have got weaknesses in the abdomen, no tone in the abdomen. What happens? Your diaphragm might start going into distensions. If diaphragm is getting distended, what is going to happen? You can have abdominal content pushing high up in diaphragm. If diaphragm is getting high up, what is going to happen to your lower lobe? It will start collapsing. What happens in functional residual capacity? They start going down. Okay, what happened to, before you know, they will start needing high amount of oxygen. The VQ mismatching will start kicking in, and all of those things. Their oxygen requirements start going up. You can relate all of these things because of time. Again, you can relate why somebody can have poor rib cage compliance. You can use paradoxical this thing to think about these things. You can think about lung compliance. You can think about why somebody can have hypoventilations. Why the hypoventilation is they are struggling to breathe that CO2. We have talked about that today. You can relate why somebody can end up having respiratory failure. As physio, we need to be able to figure out these things with them and escalate with them. All right. One of the objective things we can be doing with this patient is you can do peak of flow with them. Okay, I'll go back. How do we assess this patient respiratory parameters? Let me first of all ask us. So what are your respiratory distance you are checking with them? One of them is paradoxical breathing, which is important. What other respiratory distance are we checking with them at the bedside? Now we know that we need to assess their respiratory mechanics now, respiratory system. We know we need to be checking breathing. We know we need to be checking their paradoxical breathing, if there is paradoxical breathing. What other things are we checking? Are we looking at as physio? Please put them in the chat box. What other things are we checking? Respiratory wise, what other thing are we checking with this patient? I think it's more interesting when we discuss this thing, as opposed to me doing the whole job. No, let's just discuss. So what other thing are we checking at their bedside? Yeah, paradoxical, we have talked about that. Work of breathing, we have talked about what other thing? Beyond that, what other thing are we checking? Yeah, let's see what people have written. Thank you for responding, everyone. Yeah, chest excursion. Yeah, you're also looking at their chest excursion. There might not be a paradoxical breathing, but you are still focusing on chest excursion as well. Is it optimal? Is it reduced? You are looking at those things. Yeah. Thank you, Pretty Stella. Any other thing? What other thing are we checking? What other thing are we checking at the bedside? What other thing are we checking? Put them in the chat box. What other thing are we checking with them, with this patient group? Because being able to identify, yeah, breathing pattern, great job. Breathing pattern, yeah, paradoxical, yeah. Breathing pattern, is there in shock, abnormal shocking in and out or something like that? Yeah, respiratory rate, 100%. Yeah, you're checking their respiratory rate. Are they working hard than expected? Yeah, you are auscultating their chest. And again, in this auscultation, we also need to remember that some of these patients might not be able to take in deep breaths. And sometimes auscultation might also not be very reliable. That's another thing we also need to know. Being able to know some of these things as well will help us in making clear, analysis with our patient, in being able to figure out problem lists. Because somebody that is not taking in deep breath because they've had weak, let's say imagine somebody that have C4 or C5 or remember innervation to the diaphragm, C3, C4, C5, something like that. Remember, if somebody have had injury to any of those things, they might not be able to. And again, if somebody have had impact or if there is affectation to the intercostal or something like that, so sometimes auscultation too, yeah, we can still do auscultation, but it could also be sometimes not be reliable. Yeah, this is how we think. Okay, yeah, signs of respiratory distress. We are looking for those signs. If we need to escalate, we escalate. If we are comfortable, if they are fine, yeah, we know what we're doing. Great. What other things are we aiming at? Are we looking at? Yeah, great. Even with that auscultation that I mentioned, that auscultation might not be reliable. Again, that you can use that same reasoning again when it comes to your treatment selection. Somebody that has got injury that is not able to take in deep breath. Now, let's say, for instance, I get them something they need to be doing at the bedside to increase their lung volume. I may also want to think about how often do they need to do that thing. Because somebody that is really struggling to take in maybe breath, if I work them out, they're going to fatigue easily. They're going to fatigue quickly. So I may need to think about, I need to spread my treatment. So small treatment might be helpful than one big treatment that is going to fatigue them. And if you fatigue them, it's going to impact them again. Think about all of these things. Oxygen saturation, PT is perfect 100%. We need to be checking that as well. Cyanosis, yeah, great job. We need to be running the circulations, checking their central cyanosis, peripheral cyanosis, all of this. We need to be checking. These are signs that, are they going into, are they having oxygenation issues? Yeah, we need to be checking those things. Great job. Perfect. Can we have more? Can we have more stuff? Can we have more stuff? The more we talk, the more we pop in things, the more we can have clear clinical discussions. Yeah. What other thing are we checking with them? What other thing are we checking? Of course, clinical wise, you go to their bedside, we need to be able to pick up some certain things, look at their hubs, okay? Look at their hubs, and you can even do your A-to-E assessment here, checking all of those things. You can do your breathing, check if they are on oxygen, what device of oxygen are they on, what amount of oxygen are they on, what is their SpO2, what is their respiratory rate, check those things. Okay, if there is any concern with maybe secretion, mucus plugging, if they've gone chest X-ray, you are checking that. If there is increased amount of oxygen, they've run ABG for them, you are checking those things as well. Okay, yeah, let me see what people have written. Yeah, use of accessory muscles. Yeah, we are checking those things. They are using accessory muscles to ventilate. We are checking those things. We can see it's going to be obvious. And again, one big thing, one very, very big thing that must not be left out. And please, 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 this needs to be done. I don't know, but it's really very important is doing their FEC. FEC can predict beyond what we can pick. Even before I talk about FEC, another important thing, voice. Pay attention to your patient voice. Pay attention to your patient voice. Their voice can tell. These are small things physios can pick. Their voice can tell you a lot of things. Their voice can tell you if their respiratory system is well supported. Their voice. Imagine somebody struggling. Just imagine yourself. You are running. You are on the super pitch. You are doing heavy breathing. What is going to happen to your voice? It's going to be breaking. It's going to be breaking. Pay attention to their quality of voice. Is it clear and loud? Does it show that they are in distress? Pay attention to those things. Is their talk breaking? Is it breaking? What happened to their quality of voice? Is it loud and clear? Pay attention to those things. Don't ignore it. They can tell you a lot. They can tell you if they are going into distress. They can tell you. Or imagine somebody you've gone to see them. They've been speaking to you, and all of a sudden their voice start dropping. Their voice start dropping. Pay attention to those things. Or their family member come to you and they say, their voice, they are not speaking well again. Pay attention to that thing to ring something in your head. Okay, all right. Then vital FEC again is also very important. We need to be doing this thing for this patient. Please, please, please. Really important. FEC. We need to be doing it to them. Do it in supine position. See where they are. Normal value 3 to 5 mils or liter. Anything under 1.5, they need augmentation. Augmentation physio-wise. Anything under 1.5, if I do FEC with patient and they score less than 1.5, they need augmentation. I need to start prophylactic chest treatment with this patient. Prophylactic treatment. I need to be treating their chest. I need to be treating their chest. Prophylactic treatment. I need to now start thinking about how I can cough assist them. That is why we keep saying we need all these things. How we can IPPB bend, something like that. How I can do other respiratory support with them. I start thinking about this thing. Yeah, it could even be our incentive spirometer. But think about is your incentive spirometer. Somebody that is struggling with taking deep breath. If you do a lot of that, you can fatigue them. You can again end up. But generally speaking, if somebody have got 1.5 this thing, I'm thinking about those equipment with them. Prophylactic treatment, I've commenced it. You need to be thinking about this thing. Now, under 1 liter, they need intubation. Let me now tell you the funniest thing here. You can go to somebody's bedside and you do FEC, and the FEC is saying 1, below 1, or something like that. These people can even be on room here. This thing is really very funny. These people can really be on room here. They can even be comfortable. They might not even show signs of respiratory distress. But all of a sudden, something can just quickly change and their respiratory parameter will start failing. This is why we need to be doing these things. In fact, sometimes in the past, I have been called to see some patients on the ward in the middle of the night. They will say, the handover says, oh, this patient, they are room here, they are this, they are not on oxygen. They are ideally, by the time you look at your physio parameter, they don't even fit in. They don't even meet physio parameter. I think what the patient had was myasthenia crisis, not even spinal cord injury, myasthenia crisis. And they say, oh, they've been doing their FEC, and FEC is I think 1.2 or something like that, It's just dropping down. The FEC, and in the afternoon, during the day, this patient is walking around, they are fine, they are this thing, but the FEC is saying otherwise. And the medical team, in fact, ITU consultant, it was on neuro ITU, no, it was on neuro ECU. And the ITU consultant, they are really, really very concerned for the patient. And this patient is saying, there's nothing wrong, I'm fine, I'm this thing, I'm something, and I'm this thing. So we need to be doing their FEC. And again, so they are not having chest concern, there's no secretion, there's nothing, they are fine, they are room areas. But a good clinical expert will know that this patient, if you don't support them, something may suddenly happen, and that might be the end of them. So don't joke with neuro patients. Do not joke with physio patients. Neuro patients, don't joke with them. People with neuromuscular injuries or neuromuscular condition like that one that I mentioned, myasthenia gravis, somebody have got neuromuscular disease, somebody have got, what is it again? Spinal cord injury again. It's also another one. Don't joke with those patients. You need to be running the FEC. It's really, really important. Those nurses need to be trained for these things on the ward. Physio need to be trained to be able to do these things and escalate if there is any concern. Well, for that patient that I mentioned, what did I just did? I just go to their bedside. The consultant is there. The people that, what is it now? Critical, everybody is there. They are waiting for physio. And I stepped in. What did I do? I just do normal bed stacking. But in my head, I was like, okay, yeah, if I do these things, if this thing does not improve, I have an escalation plan. And what is my escalation plan? Carry my IPPB, give this patient some breath. I just did the breath stacking and stuff, deep breathing things and everything. And we repeated the FEC, and these things start coming up, and everybody is happy, and that was the end. But assuming I did that, I did my IPPB, no improvement, everything, they will intubate that. They're going to intubate that. So why am I saying all these things? I'm saying these things and I'm spending time and I'm spending energy on these things just to let us know that these things is really, really important. If it is not something we are familiar with or it's not in our facility, this is another thing again that we need to be saying to our team, our I don't know, our management. We need to be running these things for some of these patients. Really important. Again, physio-wise, pick-off flow is another thing that can also decide either I start my prophylactic treatment or not. Normal pick-off flow, 360, anything below 180, 160, commence your curve augmentation. Start your curve augmentation. Start doing your stuff. Because you know what that means is that patient have got high chance that they will develop respiratory compromise. Commence your treatment. And again, another thing I also need to say here is sometimes, and that is where clinical experience comes in as well. Sometimes you might go to patient bedside, they might, maybe because of techniques or something, you might be getting some wrong values. So you might need some clinical discretions to be able to know, yeah, this is a good technique. Patient is doing it well, but you are not getting good value. Or sometimes you might need your patient to run it 2, 3, 5, 3 times and look at the readings. And again, put them, this is spinal cord injury, put them in supine position. Like I mentioned, evidence has shown about 6%, in supine position will make this thing more optimized for them. So think about all this, please. These things are important here, please. All right, thank you. We'll move forward. Please, is it making sense to us? Are we getting any value from these things, please?
We are.
Thank you very much. All right, so I'm not going to talk about this picture here, but I think it's part of what I've explained the other time. Again, from physio, please, I'm going to send this slide to us. This is also what some of the predictive these things that we can use as physio to decide either we need, thank you, either we need to be doing prophylactic treatments or not. So these are, this thing is just there for us again to look at. So recognitions of deteriorations, of course, these are some of those things that we have mentioned the other time. So these are some of these things. Their GCS can start dropping. somebody being active, maybe day 1, day 2, they are now sleeping too much on the ward. We should be worried. What is going on? Why are they sleeping too much than expected? It could be maybe they have now started retaining CO2 or something like that. We should be worried. Now, be worried. So they might need ABG. Again, think about that. So other signs of deterioration, their SAT might be dropping, work of breathing, and a lot of those things that we have mentioned. Anyway, quality of voice as well. Pay attention to those things. Cough strength. Cough strength. You know, even with that, even if we don't have all these BFC or something, there's no excuse for us. There is no excuse, like I used to say, there is no excuse for us. Cough strength is also important. Again, pay attention to their cough strength. These might also show that, oh, this patient is deteriorating. Pay attention to their cough strength. Prophylactic treatment, we have mentioned some of these things. Of course, some people might need NIPI, they might need cough assist. You might need to be doing your prophylactic treatment 3 times in a day. It might be QDS, it might be 4 times in a day. You might need to be doing maybe on-call services, maybe to support them or something like that, depending on where you work. And again, ACBT, deep breathing exercise or thoracic expansion, whatever, or inspiratory incentives parameter, like I mentioned, please consider fatigue. Don't overdo these things. If you overdo these things, some patients can also fatigue. You can also fatigue them. Consider spreading this thing out, spreading it out. Get nurses to support them, get family members to support them. It's not necessary that physio, it is when you are there, you have to do like 20, 30 times of that breath or something. You might fatigue them. Think about, so it should be patient-led. It should be patient-led, and it should be patient, it should be selected. Your reps or whatever thing you have to do must be selected by your patient. Pay attention to those things. So, managing secretion, our MAC is also part of something we can do, part of our treatment tools we can do. I'm going to show you some pictures about MAC. You can mark them, you can do thoracic MAC, abdomen MAC. There are different techniques with MAC. Again, these are practical things, but we need to be trained and we need to be able to do all of these things. So, again, some people they might need to be on humidified oxygen. Some people might need nerves. They might need mucolytic agents. They might need bronchodilators. Some people might need to go on NIV, like I mentioned, to offload their work of breathing. If somebody's FEC is dropping as well, some people might need to go on NIV to support their respiratory mechanism, something like that. And some people might need to be intubated. Some people might even need trachea. There are some, what is it now? There are some spinal cord injuries that can also need trachea to be able to assess we have had discussion about trachea in the past, for you to be able to assess their airway, for you to be able to support them, for you to be able to ventilate them on the ventilator properly or something like that. Some people might need to go on trachea, and you commence your trachea management. As a neurophysio as well, as a neurophysio, again, you need to be training respirations. I mean, what is it called? You need to be respiratory competent. Unlike what we do, like, oh, it is only, I don't know, it depends, but I just believe that we need to separate outpatient and inpatient. Outpatient physio must be separated from inpatient physio. If you want to be outpatient, stay in outpatient. If you want to be inpatient, let's have some inpatient physio and let's be trained. If you are neurophysio, you should also be trained, because on your neuro ward or your this thing, you're going to have some patients that also need some respiratory support. So that might be the case anyway. So there are a lot of things you can do. Abdobinder is there. Inspiratory muscle training. It might not be something you want to quickly start. It might be maybe later on down the line, because it's going to, there are some devices you can use that can offer some resistance, but you don't want to commence that at day 1, day 2, or something like no. It's not something you are thinking about. So think about when all of these techniques. These are just some of the techniques you can have in physio toolbox that you can select. But again, this thing needs to be patient-led. They need to be selected based on patient needs. Let's move forward. What is this one? Have I written here? Let me see. Oh yeah, what position? I think we have discussed that. So let's move forward. So manual assisted cough is just one of our respiratory skills you can also use with what is the spinal cord injury patient. And what you can use this thing to do is just to facilitate expiratory flow. And how do you? Let me just show you some picture. Yeah, you can have something like this. So this is infradiaphragm pump. You can have this. You can do this for your patient to support them. You can see on the other side as well. What's it going back? So you can have that. You can have this one as well to support them. Think about that. Even if we don't have cover assist there, but there is no excuse for us. There's no excuse. Like I keep saying, there's no excuse for us. So you can have this as well. These are, but these are like somebody that they've been progressing them. They can sit up. can continue your mark with them, something like that. So this is thoracic mark again. You can do with them if there is indication. Yeah. These are here we had joint. Of course, in my previous section, you've been seeing some of these things. You can see this NIV, BiPAP or CPAP, whatever. You can see this MHI, minor hyperinflations or bagging, whatever you want to call it. You can see covasses. You can see NIPI or covasses. You can see belt or IPPB. So these are some of these things we can use to support our patients. All right. So indication for all of this now, I will still talk about it. I think there is another part of these things that talk about these things. I will still talk about all these things in the future. Let's move forward. So beyond the respiratory system, what other things do we need to be assessing for? Of course, we need to assess their strength. Is really very important. But what we say when you are assessing the strength is be aware of compensation. Be aware of compensation. For instance, now, if somebody have got, if you need some patient to do, let's say you ask them to pronate, for instance, you can have people initiating it from the shoulder, like internally rotating their shoulder. As physio, this is our job, this is our bread and butter. You should be able to figure out, is this patient compensating or is he actively doing it? Are they actively using the prime muscles or they are compensating from other area? So what I would say is palpate the muscle you are testing to be able to see if there is action in that muscle, they are compensating from somewhere else. Another thing, you can ask somebody to maybe to extend their wrist joints now. They might be pronating, they might be supinating their forearm. That might be a compensation. Think about all of these things. You can have somebody, if you have somebody to flex their shoulder joint now, for instance, they might be using their shoulder depressors. Even in our stroke patient that we see, we should be checking those compensations. It's not just 3/5 muscles. Are they actively doing it? Are they using that muscle group or they are compensating from somewhere else? That compensation, because here in spinal cord injury patients, you know, they are in that this part can be innervated, that part might not be innervated. For instance, I give you another example. Let's say somebody has got 6/6 injury, just like our patient. Our patient 6/6 injuries, you have elbow flexors, but there is no elbow extensors. There is no tricep. Tricep is innervated by C7. Right? The patient has got elbow flexors. They can actively flex their elbow, but they cannot extend their elbow joint. Some patient, if you now ask this kind of patient group now, for instance, to extend their elbow, they might be compensating for that using graffiti. Try to figure this thing out. So do your sensation, proprioception, all those are feature this thing. And again, your patient psychology, the way they are presenting, their mental health, all of these things. Their belief, everything. Check those things at their bedside. It's also very important. So spinal shock is also another thing that is also important here. It's just what is it? There is lots of reflexes. No, and this again depends on your patient. It varies from patient to patient. Some people it might be 60, some people might be 2, it might be 10. It varies from patient to patient. But how do we know there might be returns of when you start having returns of reflexes? This is when you start, to know that these things are coming back. If you are unsure again, speak to your medical team. You should be working closely with them. There is no one no one is overall. So work with your medical team to know some of these things. So I won't talk about it because of time. So other complications that are also important that we need to be aware of. Sorry, are we still there? I'm trying to rush this thing because of time now. Are we still there, please? Hello?
Yes, sir. Yeah, with you.
Yes, sir.
Yes, sir. We are with you, sir.
We
All
are
right,
with
thank you very much. Thank you very much. So other complications that we also need to be aware of is cardiovascular. Let me go to cardiovascular system. DVT, pulmonary embolus, they are not very far away from this patient. They are not very, very far away from this patient. At physio, how do we help this patient to prevent this thing? Think about TED stocking. And TED stocking, what evidence is recommended? Get them above knee TED stocking, not below knee. Don't forget this patient, I would say 50% chance of getting TED and DVT is really very high. It's really, really very high. Why? We can clearly reason these things. They've not got pump activities in their lower limb. They can't dorsiflex and plantar flex on the lower limb. They can't do that. If you've got that injury to affectation to that area, like in our patient 6/6 injury, they've not got that. So think about that. Again, this patient will be sedentary. They will be in bed. And again, one thing don't forget again, autonomic disruptions. It's also something that happens to these patients as well. Not just motor sensory, they've lost some autonomic, there is autonomic dysfunction. Even coagulations in their blood, it becomes abnormal. That might be high. So again, this patient, they have high chance to have DVT. So think about what we can do with them. Compression stocking is really important. And again, if you can get some motor meds, some people support them to be able to put their leg, to be able to cycle actively. Again, passive mobilizations, you know, when it comes to active mobilization is really, really what can help with circulation, honestly. We all know that, like, indication for passive and people. Passive mobilization may just be more for preservations of joint or rigidity. But get them to do things actively. Get them to do their lower limb actively, to use their lower limb actively is really important. So think about that. In terms of cardiovascular wise, again, hypotension is also very important. I think I will just take that with, I will just quickly talk about autonomic dysfunctions, then so that I can just take this thing together. Autonomic dysfunction, again, is also something that spinal cord injury patients, they also experience. Please, autonomic dysfunction and dysreflexia. Autonomic dysfunction, I think they are quite different things. Autonomic dysfunction is, for instance, you can find people with maybe low blood pressure, they are bradycardic, they are something like that. So now, how do you support these patients? How do you support them? Now, so let me make this thing this way. Let's say, for instance, we've got this C6 injury patient. They've been in bed for 6 weeks. They've been in bed rest, recommended by medical team. Now, we are supporting them in bed. We are doing our respiratory support in bed. Now, they've been cleared that we can start moving them out of bed. In my head, I'll be like, yeah, so I need to be aware. This patient might have some blood pressure issues, something like that. They might have some blood pressure issues. So just think about these things as orthostatic drop, postural drop. That thing we call postural drop. Somebody that's been in bed for a while, somebody that had some autonomic disturbances, I may just bring them into upright position, their blood pressure might drop. Have that thing behind at the back of your head. Have that thing at the back of your head when you are working with spinal cord injury patients. It has happened to people before. They will just bring them up, their blood pressure will their blood pressure will drop. The patient may have vasovagal, some people might die. Please, always have that at the back of your head. So how do you progress this patient? Okay, first of all, if I need to go to their bedside, first thing I want to do is I want to look at the nursing chart. Look at the readings, the blood pressure readings, the heart rate and everything. I look at those trends. I have to look at their trend. After that, okay, if I'm not really, really very happy with the blood pressure, or the blood pressure, systolic blood pressure is not on the high side. Normally, what I always want is I want the blood pressure to be on the high side. What can I do? I can speak with the medical team. They can give some medication that can, shoot up their systolic blood pressure, their blood pressure to be on the other side. Sometimes they can give them midodrine, they can give them epinephrine. Yeah, they can give them those medications. And physio-wise, what can you do? You can get them abdo binder to support them, and abdo binder is also going to support their their tone in abdomen. It's also going to help their blood pressure. It's going to compress the big vein is gone in your abdomen. Your what's that again? Inferior vena cava, something like that. It's going to squeeze that. It's going to compress that, which is good. So you can get abdo binder. You can think about your above knee test stocking again. And again, if you need to now start moving those patients, again, you may not first think about, let's get them to sit edge of bed. What are you doing? Think about gradual thing, because behind your head, in your brain, you know that this patient might have blood pressure. Start thinking about like gradual progression in bed, first of all. Maybe I see them 30 degrees today, see how are able to tolerate that.Maybe for 2 days or a day, if they are tolerating that. Maybe for 24 hours, I can bring them 60 degrees. If that is fine, if they're able to do that. Again, I will still not do the edge of bed, because edge of bed sitting might be really, really challenging for a lot of these people as well. Some people, by the time you bring them to edge, they might tell you that you feel like their head, their upper body is not there. Their head or their upper limb is floating, because they've not got lower part. They cannot feel their lower part. The only part they've had is just their head and maybe some part of their upper limb. They might feel like that part is floating, something like that. And again, it might be really challenging for these people. Don't forget, they've not got to abdomen, they've not got abdotone, they've not got anything. Again, blood pressure might drop. It might be because for you to get somebody to sit edge of bed, supported sitting edge of bed, is an active transfer. It can really, really be challenging to your patient. So what I would say is do progressive sitting up in bed with abdo binder, with test talking, do those things in bed. If they're able to tolerate those things, then I might then start thinking about passive transfer. First of all, let's build them up. Let's build them. This is rehab, dental rehab. Let's build them up. I might think about let's hoist them, sit in space chair, supportive chair. Let's host them to those things. Let's host them to sit in space chair. Even if we put them in sit in space, it's still sitting we are training. We are training them to be able to be tolerant. We are training them to be able to work against gravity, to be able to see how they are able to cope with their blood pressure and everything. We can do that. Even within this space, I can still tilt them backward. I can elevate their leg and this thing. We need all these things. We need all these things for safety, for safe patient care. We need them. We cannot overemphasize these things. It's not a joke. We need this thing. All right. So after those things, what else? From there, I start, let's do 2 hours today. Let's do 4 hours in chair. Let's do this thing. Let's hold them back. Let's see how they are tolerating. From there, we start building things up. We start doing, let's do edge of bed sit and those things. That's great. And if I've also equally got patients, they are not correlating that hosting to teeth in space chair, I might start thinking about let's do teeth table then. Let's start for teeth table. I'll still do my abdo binder, I'll do test talking and everything. The numbers of stars that needs to be there again, because you can bring people to 20 degrees and their blood pressure will just drop. And they may have big. You need senior staff to be there, and you are monitoring their blood pressure when you are doing all these things. You don't want to be joking with people's life, because people can be proud that somebody have got spinal cord injury does not mean that's the end of them. So we need to, this is rehabilitation. We need to support them. Senior members of staff, 4 staff, 5 staff, everybody needs to be there. Senior members. And we are gently progressing them with T-table. And again, that T-table, beyond blood pressure, again, if you are able to get them into erect position with time, so that can also stretch their calf muscles in the leg and everything, the ankle, because you still need that tone in the leg as well. For them to be able to put that leg on the wheelchair, they need good tone again. And again, that can also help with their pumping activities of the leg again. So these are things we need to be able to figure out. Beyond blood pressure issue and this thing, other ones might have bowel bladder. Even your standing, if you are getting them to standing with that T-table, that can also help their the bladder function, their bowel function and this thing. Another thing we also need to be aware in this patient is impaired thermoregulations, temperature. Because of autonomic disruptions and these things, some people, they might have issue with temperature, warm, cold, and these things. If it is cold, we need to support them. They might not really be feeling these things. If it is warm, there might be disruptions. We need to be able to lose their shirt and everything. We need to be supporting them. Beyond muscle movement and this thing, we need those clinical reasons for all of these areas. All right, let me see what that here. I think I've talked about that. So I won't discuss bowel bladder. It's a big discussion on its own. I will just skip it because of time. I will skip it. So, but I like to talk about this autonomic dysreflexia. The fact that I skip this bowel bladder is really, really a big discussion. As physio, bowel bladder, you need to be able to think about how you want to support your patient. Because of time, I won't talk too much, but I just want to pinpoint some few things here. If somebody is just losing urine anyhow and this thing, have you think about pressure damage? Have you think about how they can quickly catch infection with that? How they can die because of infection? Have you think about how we can routine working with the nursing staff? Even as physio, let's say we are maybe later on this patient get discharged, they are back home now or something like that. Have you think about how that routine? Have you think about if you go to them, let's say you are going to see them as community physio now, are you able to identify if there is infection going on, maybe with the their catheter or something? Are we able to? So it's a big topic on its own. It's a big topic. So let's just keep this. We can have some discussion later on. So autonomic dysreflexia now. So autonomic dysreflexia is a bit different. Generally speaking, you might find stimulation, maybe the bladder is over full, or maybe there is infection in the bladder, or maybe there is constipation. It's just usually issue with bowels and bladder, generally, most of the time. And in some patients, maybe they've got tight clothes somewhere in their body or something that is stimulating. Let me make this thing very clear. If somebody have got injury above T6, let's say T6, 7, usually the injury is usually above T6, people that have autonomic dysreflexia. Now, if there is notorious stimulation from the bladder from anywhere in the below the level of injury now, so what will happen is that will come to the spinal cord. Now, if that comes to the spinal cord, don't forget the injury is at level of T6. That notorious stimulation is unable to go high up to the brain. So the way the body will sense these things is sympathetic pathways have been stimulated. So there will be rise in blood pressure below the level of injury. There will be the heart rate will also get rise below the level of injury. Now, if the blood pressure is high, don't forget in your neck you've got baroreceptor in your carotid artery that can sense blood pressure. That one in your neck is going to fight and give information to the brain. And what information I will give to them, please brain, please regulate the blood pressure. This blood pressure is too high. And the brain will now stimulate your parasympathetic system. The parasympathetic system is going to stimulate it through the bigger nerve. That bigger nerve is just different nerve that goes to different area in your body. What that bigger nerve will do is it's going to slow down your heart rate. It's going to try and reduce your blood pressure. It's going to try and what other thing did they do? Again, what you see generally in patients is you might find flush face. They might start complaining of pounding headache, something like that. This is what you find in patients. So what I'm saying with autonomic dysreflexia is a lot of jargons. Below the level of injury, you might find high blood pressure. Above the level of injury, patient might start having low blood pressure, heart rate, or something like that. This is not normal. This is a medical emergency. This is a medical emergency. Let me just show you the signs, what you might find in patient, because you won't be able to see those fibers flying up and down. You might see dilated pupil. You might see they are having flushing face, face. So they are sweating heavily in their head. Some people you check their blood pressure. Their blood pressure is really high. Again, some people might be complaining of headache. When you sense this, what do you want to do? This is emergency situation. If you don't take care of these things, some people might have brain bleed, hemorrhagic stroke. Some people might have heart attack. Some people might imagine somebody having stroke on top of spinal cord. It's going to be terrible. So what do we want to do? This is medical emergency. Speak to the medical team immediately. What do you do? And in their bedside, think about what you can quickly do. Oh, if their clothes is very tight, loosen their clothes, free those things, because those things can also stimulate those pathways. Again, from physical perspective or from everybody there, we should also be trained that we should also know in our head that sit this patient up. Their blood pressure is high now. Let's sit them up. Because we know that by the time we sit them up, their blood pressure is likely to drop. Think about what we discussed earlier, autonomic dysfunction. In this patient, quick emergency, this thing that people will do, by the time they get to their bed, their blood pressure is high, you can see flush skin, you can see they are complaining headache or they're sweating, people will just, let's sit them up. We sit them up first. We know that their blood pressure is likely to be down. If their blood pressure is down, and again, the medical team, they can think about, even the nursing team, they will start looking at the catheter. They will start checking their catheter. What is wrong? Is it blocked? Is it infection? Is it this? Is it that? They start looking at their catheter. And again, everybody, you look at, you loosen up their shirt if it's too tight or something like that. Think about all of these things. It's really, really important that we are aware of these things for safety, for patient safety. So far, think about your autonomic dysfunctions. If you need to start being a regular spinal cord patient, autonomic dysreflexia, notorious stimulation below the level of injury that can cause high blood pressure, flushing skin, and all this. This is medical emergency. Think about these things. Think about these things for safety reasons. That's really important. So I won't talk about sexual. This is another big thing again. I won't talk about that. So I will just go straight. For other management you can do for this patient, of course, they need constant 24 hours positioning. They need to be constant turning. At initial stage, it might be log rolling, maybe the medical team. These are what we need them to be documenting as well. Ask them, have them check their clinical reasoning as well. And again, put whatever they are turning into your own physio things as well. Do they need log rolling for how many period of time? If there's log rolling, how many members of staff do we need? We might need 4. Somebody, like this our patient, I've got cervical injury. Somebody might need to be in the head. You man the head and the neck. Somebody will be on the other part. So for spinal, other people will be on the other part. For spinal alignment, we should be trained to be able to do these things, not just moving patient anyhow. Now, appropriate, what do you call it now? Bed for your patient. Are they on appropriate mattress that can prevent pressure sore and all of these things? We think about those things. What kind of supportive chair do they need? Do they need seating space? Think about this thing, regular turning, nursing staff, family. Teach them all these things. They need to be turning this patient to prevent pressure damage. How do you support the edematous hand? Because if they've not got that contraction in the wrist, in the foot or something, they might start retaining fluid. How do we support those things? Elevations, all those things. Great. So, like I mentioned, your first mobilization again, you don't just say, oh, physio, let's start moving. No, you still need to speak with medical team if once they're happy to move out of that flat positions. Then you start progressing your rehabilitation. You need approval from them. Then they start progressing your rehabilitation and all of those things. Think about waste transfer. Think about sitting space. Think about, remember your autonomic dysfunction. Remember dysreflexia. This thing can happen. This thing happens a lot. These things are not just textbook teaching or classroom teaching. All these things happen a lot. And we need to keep having trainings on these things. We need to get people to be aware of it. It's really, really very important in all these things. So range of motion are part of physio stuff. While they are in bed, even that 6 weeks or 8 weeks or whatever that time they are having their bed rest, we can go to their bedside, be checking their ankle tone, documenting their ankle tone. Are they able to pantograde? Is there any restrictions? Are we able to move it passively? All these things are very important. Do they need maybe AFO or PAFO or whatever things to help to maintain their tone? Because we know this tone is very important. If at the end of the day we're able to rehabilitate them, they can sit the way they can do this thing, they might likely end up in wheelchair. They need those tone to be able to put their leg on the wheelchair. All of these things are really, really very important. So log rolling, this is just a picture showing log rolling. How patient can roll, independent rolling. These are part of physio things. Maybe later on in the rehabilitation, it might not even be, maybe they've been discharged or something now. You might need to get them on the floor, teach them how to roll. You might need to get them on the plinth or something like that, surface, teach them how to roll, teach them how to do things, transfer. All of these things are really, really, really very important. So I'll just stop here. Oh, before I stop, this is another thing. This is graph again is also really, really, really important. If somebody has got C6, C7 injury, you also need to be aware as physio, as tenodesis, you need to be aware of and teach your patient how to effectively use this. To optimize some functions in the upper limb tenodesis. So it's just, for instance, now you relaxing if I ask you guys to relax your finger now, if you just look onto your screen, if you relax your tenodesis is just, for 6/6 injury now, just like in our patient, they've not got any finger flexions. They've not got any finger flexion. If I ask you guys to just relax your finger, and I ask you to just actively move your wrist like this. So if you actively extend your wrist, so what happens is the thumb here will just come over the index, your fourth finger, indirectly. So this is what, if I relax my wrist now, if I move this up, something like this, this is how they do it. So think about, if you are doing, maybe you are helping them to do, you are doing some stretches with them, or you are getting them to weight bear on the upper limb. Think about you will be dealing with this patient, that you will not get this patient to lose that tone, to be able to do this tenodesis graphs. I don't know if I'm making sense. Because with this, some people might still be able to use this function to be able to do some maybe grasping, feeding, all of those things. So think about that. So if somebody have got, but again, for you to be able to start thinking about how to optimize this thing for patient, it has to be maybe 6/7 complete injury. If it is incomplete injury, they might have chance for recovery. Their chance might be there. There might be chance for them to recover well. So you may not want to promote that in incomplete injury. But for complete injury, think about how you want your patient. 6/7 injury. Think about how you want to optimize these things with your patient. And again, that means if I'm doing any stretching program with them, weight bearing program with them, I have to be thinking about how I will not further stretch, give them stretches that will make them to lose maybe the tone in the finger or the wrist joint or something like that. So think about all of these things. So there are some supportive aid as well that you can also use if like this person that have got 6/6 injury now, for instance. We want to promote tenodesis graph, something like that. I might go for this glove, something like this glove. What this glove does is further promote flexion at the metacarpal joint. You might think about that. They use it here oftentimes. So think about all of these things. So this other picture here is just showing that if you need to do weight bearing activities, I want to make them to weight bear on their knuckle, if that is possible, and not very painful for the patient. I'm supposed to weight bearing on the, what do you call it now? on their flat palm. So think about all of this. Cardiovascular wise, if they are able, get them to do some ergometries. If they cannot, of course, think about propelling wheelchairs around, using their upper limb to be able to do all of those things. Is really, really very important. And from there, the patient is discharged. Outpatient, this thing, continued line of management. So I'm going to stop here today because of time. Thank you very much. Any question before we go? Any question, any comment? Yeah, somebody have written here. So I have question. We are managing patient with paraplegic secondary to TB or spine. We are doing passive mobilization, call-up exercises, tactile stimulation, electrical. Oh, this, where is it gone now? Where is it? It's gone. Sorry. Yeah. So we are doing call-up exercises, tactile stimulation, call-up exercise, tactile stimulation, and EMS. Is this treatment plan appropriate? Yeah, I would say they are I would say they are appropriate, because I do not really know the level where you are seeing this patient. But I think there is no treatment plan that is right or wrong for patients. But what we just need to remember is, what are we trying to achieve in that patient group? Is this patient, have they got, are we managing them for restorative purpose, or are we trying to gain compensation? That needs to be defined. We need to define what we are targeting with our treatment plan. We need to define it. Are they really good chance of recovery? We need big question mark. We need to define that. And again, in everything we are doing, I will say it, function is really, really very important. Think about function. Think about optimizing what they've got, you can see, what movement or what tone or what strength they've got. Think about how they can use that strength to maximize function, first of all. Think about those things. And again, define your treatment. Do we really need to be doing these things for this patient? We need to define that. Do we need to go by compensatory strategy? We need to do it. Is not all patients, like I said, it is not all patients that they need things. It is not all patients that need tactile stimulation. It is not all patients. So we need to define those things. What is the chance of recovery? Why are we doing these things? So do we need to teach compensation? Do we need to help them maximize what they've got? Do we need to teach them some of these things as well to self-manage themselves? We need to define all of these things. So that's what I'm going to say. All right. So I think you said the level is at T12 injury. Again, we need to know, is it complete injury? Is it incomplete injury? We need to think about that as well. If it is incomplete, yeah, they've got chance of recovery. Yeah, we can crack on with our stuff. Yeah. If it is incomplete as well, yeah, there's no crime in trying, but think about what we are feeding to patients. Think about patient, what is it again? Think about the way patients are taking in those information. Think about their chance of prognosis, their chance of recovery, and how patient, what it means to patient, whatever we are doing. There's no crime in trying, but think about the way patients are taking those things. So it will not be like we've tried 2 years, 3 years, there is no recovery. So we need to actively define those things. Why we are doing that? Is it complete injury? Is it incomplete injury? Do we really need to be doing it? Do we need, and again, in overall, whatever we are doing for patients, function. Teach them wheelchair skills. Teach them to be active. You don't want people to come to physio facility and go back home and be in bed for the next 2-3 days, 5, and not being functional, no. Teach people to be functional, to be able to do activities on their wheelchair, to be able to self-propel wheelchair. If there is any adaptation we need to be doing with them, toilet, home-wise, like, do they need anything in the toilet? Do they need, because we know, so that pressure on the family can be relieved beyond our tactile stimulation, beyond those things we are doing. Think about function, ADLs of this patient, really important. There's one thing I'm going to say, together with what fantastic job you guys have been doing with this patient, is add function to it. Somebody can go to their home or our OT. Of course, these are the job of the OT as well. Take measurement of their toilet time. Correlate that into the patient function. Think about wheelchair transfer. Are they able to transfer from bed to the wheelchair? Or is it just family dependent? These are what we need to be teaching them. Teaching them how to actively use, what is it now? The upper limb to be able to complete transfer from bed to chair, from chair to this thing, pivot transfer, and what is it now? Banana boat transfer. Teach them all these things. This, I think, beyond tactile stimulation and this thing, that functional part is really, really very key. Teach them what they can do in chair, brushing their teeth, how they can transfer to maybe in the bathroom. If they go, you can guide them to get a chair in the bathroom. How they can transfer from their wheelchair to the chair to be able to wash themselves. This is really, really very important beyond impairment. Remember your ICF model. Your ICF model. Beyond impairment, think about what is it now? Beyond impairment, think about activity limitation. What patient is limited in? Think about what is it? How they can do their washing, dressing, those their idea. Think about that. Participation restrictions. Think about those things. Think about their environment. Do they need any adaptation? Use your ICF model. What do they need? Personal factor beyond our rehab. And what is the patient? Explore patient belief. What are they thinking? So are they thinking they are not relevant again? They are very relevant. They are very, very relevant. It's just, again, sometimes it's just boils down to practitioners that are seeing some of these patients. It just boils down to their hope is not lost. They can still be functional on the wheelchair. So give them some of these things. So use the ICF model, defined, put them on these things and defined and set clear plan and clear goal with them. But beyond everything, function is really, really important. Function is really, really important. Because the chance is there we can do this thing for life and there might not be recovery. But some people could have gone through, let's do transfer, teach them transfer, be active, teach them how to move around, teach them to be functional. They can still be active, they can access our community. Again, this is where government comes in again. Our road on the street, are they accessible? Are they wheelchair accessible? Our public facilities, are they wheelchair accessible? Again, we have seen some places where physio facilities in the upstairs. Our patients that are coming with wheelchair, how are they going? And there's no lift, there's no stair lift, there's nothing. What is this? So some of these things we need to be putting in consideration. We need to be treating to authorities. The fact that somebody is disabled does not mean that is the end of you, does not mean you should not be relevant again. No, this is our job as physio. We need to be educating people. No, you are relevant. You are relevant. You are much more relevant. So let's think about these things. I don't know if I'm able to answer those questions, Ma. Any other question before we go? Final call.
Yes, sir, please. I have a contribution to make on that question. That question on paraplegia, secondary to tuberculosis of the spine. So I would like to advise them that they stop call-up exercises because they are strengthening the abdominal muscles. At the same time, they may predispose the patient to having a gibbous because the spine is already compromised. I mean, that T12, yes, it's not strong enough.
Yeah.
So if they can stop call-up exercise, and then their passive movements should not have a rotatory component. They should just do flexion and extension. Meanwhile, flexion of the hip should not be beyond 90 degrees.
Perfect.
So that's my contribution I want to make on that question. Thank you.
Yeah, thank you very
also,
much.
The patient should also be on a spinal jacket in case he's not on any now to protect the spine.
Thank you very much. Thank you for even prompting me to be able to speak about that. It's really also very important again that we put final precautions as well into place in some of these patient group as well. It's really important. Like she mentioned, so this patient might benefit maybe from TLSO, something like that, to support their spine, to manage pain, for comfort. The TLSO might even be for comfort. Sometimes it might be for stability, depending on severity of the patient injury. Think about these things and think about some of the exercises you want to be doing. You don't want to do exercises that will further put pressure on the spine, like she mentioned. I just read that, but I didn't even pick up that. It's really important. If you need to do any exercises or any flexion or any stretches or anything, don't do something like she mentioned. Imagine if I'm stretching, if I'm doing flexion now to 90 degrees or something. If I'm doing repetitive of that or something, I can be putting some pressure. And I'll be putting some pressure on the spine. Think about all of these things. Think about all of these things. And again, it could be again speaking with, I don't know where this patient is being seen or something. Speaking with medical team as well sometimes could also be helpful in some of these patient group as well. Looking at their MRI, looking at like the level of the injury, how the amount of injury they've got is also very important. And again, for the braces as well, that the need for that braces, if there is need for it, needs to also be defined. Is it for comfort, or is it for what is it? Is it for stability? If it is for stability, they might be needing to be putting that jacket on every time, especially if they are transferring or something. But if it is for what is it now? If it is for comfort, to manage pain, to make it, to support their spine for comfort, yeah, it could be, yeah, if they like it, if they want to, yeah, all these things need to be defined. I think part of this section is also about braces. I'm happy to come down to talk about some of these things as well. So thank you very much for that contribution. Thank you, everyone. Yeah, instead they should do more of isometric trunk. Yeah. Really, the question is, some of these things, what do we really want to gain? That is the question. That is the question. What do we really want to be? What do we really want to gain with these things? Somebody have got complete injury, for instance, and I'm suggesting them to rigorous isometric electric trunk. What do you call this PNF? These things, alternative isometry. What is the other one again? What do we really want to gain with these things? Yeah, it could be somebody doing it actively, like rolling, like just get them to do. You might not necessarily to just resist it, make him no. But somebody doing rolling, like I mentioned, the goal should be on function, keep it function, get them to transfer, get them to roll, get them to do functional tasks. I think I will much more align with some of these patient groups as opposed to rigorous, let's do practical, no. I will be more aligned with function, keep them function, make them functional. What they've got, optimize that function with them. Teach them how to transfer, floor transfer, from bed to chair, from chair to teach them all of those things. It's really, really very important. Whatever techniques, active techniques, like I mentioned, decide, are you for active, are you for compensation? And what do you want to gain? Since you've been doing that, what is your achievement with them? What have you achieved? There's no reason if we've been doing something with objective, we are not, there's no point discontinuing it and try something else with them. So we need to review, we need to keep reviewing our treatment, review this with them. Is it working? Why am I doing this thing with them? It has to be defined. Thank you very much, everyone. Any other question before we go? Yeah, and ensure that the patient compliant with medical. Yeah, really important. Thank you very much. All right, so we're going to end this meeting here today. Thank you very much. It's been a nice time with us.
Thank you very much, sir.
God
bless you in Jesus' name.
God bless you too. Thank you. All right, see you next time.